And uh, Good morning, everybody. Thank you for joining us. I'm Megan Lechkowski. I'm with PA Families Need Nurses Now, which is a program of Vision for Equality. We're going to just let a few minutes go by so that some other folks maybe who are trying to get into the Zoom can have a few extra minutes to get into the Zoom, but we're not going to take too long. We want to get started. We want to give you all this wonderful information that we've compiled and get to have some great conversations. So I will mute momentarily while I get some housekeeping done on my end, but we should be starting in about 2 minutes. Hi, I'm back. I am We are recording. We are streaming live on Facebook. If for some reason you have difficulty accessing this on Zoom going forward, you can view this live on the PA Families Need Nurses Now Facebook page, which is www.facebook.com/PAFNNN. But hopefully we all stay connected and can stay together here on the Zoom. I'm Megan Lechkowski. I'm the program manager of PA Families Need Nurses Now, which is a program of Vision for Equality. This is our second nursing summit. Last year we had a nursing summit in 2019. It went really well. A lot of work has been done since around the issue of the skilled nursing shortage, and we're very excited to present all of that information and to share new ideas and to have some wonderful conversations today. So thanks to everybody who's joining us. We have some great panelists, some great speakers, so I'm not going to say too much more. I will just do a little bit of housekeeping in the beginning. We will be hosting a slideshow. So if you are on by Zoom and you have your screen available, you will see some slides going by. And for those of you who are joining us by phone, the slides will be sent out after the event. So you will have access to this information that we're referring to after the fact if needed. I know we have some folks continuing to join in, so hopefully they'll jump in and continue on with our theme of the day and our the culture that we want to maintain. So a few housekeeping reminders is just to please remain muted during the presentations. We have a lot of folks on today, and we have a lot of wonderful people giving a lot of interesting information, and we want to be able to hear them really clearly. So it's very important that you keep an eye on your mute button. We appreciate it. If you are joining by phone, a Zoom feature that should work for you is that if you want to raise your hand to speak, there is a little icon you can, if you are live on Zoom, you can see the raise hand icon, and that'll let us know you want to make a comment. But if you're phoning in, you should be able to press *9, and it will alert us that you'd like to ask a question or make a comment. For the folks that are in through Zoom, please utilize the chat feature. We're going to be using the chat box to field all questions and comments, and you are able to raise your hand in that. And we will, when the time is appropriate and when we have it open to a Q&A, will Amy Millar, who's helping out today from Vision for Equality, will field those questions and let us know what they are. And as always, if as much as possible, please keep your sharing brief and related to the topic that's being discussed. We're really excited. We have a lot to get through today, so we want to make sure that we give everybody their time. One of the other things that's really important to remember is that we're all here coming together to foster a productive conversation. We welcome honest feedback and candid dialogue that's respectful to all. We strive to recognize that everybody comes from a different perspective and a different set of experiences. We're willing to try to see things through a different lens. And we recognize that progress will come from maintaining solutions-based conversations. So in the spirit of that, just remembering that we all have our own experiences, and they're all valid and important to this conversation. We have a quick roadmap for the day. We're going to start out with a welcome. We're going to have a keynote address. At 10 a.m. we'll do some, since the summit, I'll present on some stuff that's been going on since last year. 10:30 we'll have a report from OMAP. 11 o'clock we'll hear some really interesting data from a home care nurse survey. 11:30 the panel discussion will happen with caregivers or nurses who are in the field. We'll have a break at 12:30. 1 o'clock we'll come back for session number 1, which is raising voices. It's around advocacy that caregivers and providers alike can participate in. And 2:30 the breakout session 2, which is some information about better ways to partner in care around shift nursing. So we'll have some tools and information that both caregivers, nurses, and agencies especially can use in really fostering this relationship that's so important in providing whole individual care for those of us who are caring for medically complex individuals in our homes. So without further ado, I'd like to introduce Charlotte Roten, the Interim Director of Philadelphia IDS. IDS has been wonderfully supportive of Vision for Equality throughout the years, and IDS is the reason we're here having this summit today. So thanks, Charlotte.
Thank you, and good morning. Good morning, everyone. It's wonderful to virtually have you all here today. And welcome to all the individuals, parents, families, nurses, home care professionals, stakeholders, and speakers. I'd like to welcome each of you to the second annual and first virtual, the 2020 Partners in Care Nursing Summit. As Megan said, I'm Charlotte Roten, Interim Director at Philadelphia Intellectual Disability Services, and I'm delighted to be here today and to support today's Nursing Summit. Again, I'm excited that you're in attendance to participate this year. If you were here last year, you heard the powerful testimonies of caregivers. These testimonies highlighted how families who rely on in-home nursing are suffering from the shortage of nurses and lack of consistent coverage to safely care for their loved ones at home. Along with the testimonies from last year, those in attendance also created impactful takeaways and unified messages and solutions to create better situations for nurses who support individuals to live at home surrounded by their loved ones. This year's summit will continue to build on some of those messages and takeaways. One of the outcomes from last year as you've heard Megan say, was the creation of the grassroots family-led program, PA Families Need Nurses Now. This program was supported by Maureen and Dia Visions, who actually brought one of the parents, Megan Lechkowski, on board as the program manager. You've just met her. In addition to Megan, several other participants from last year have also stayed involved, but none more than Victoria Salerno, Gloria Schatz, and Dana Casserly, who now make up the PA FNNN Volunteer Advisory Council. In its first year, this new program has made strong progress in elevating the family voice while creating and fostering partnerships with the many groups and systems that impact the ability of their loved ones with medical complexities to live healthy lives in their own homes and communities. PA Families Need Nurses Now, with the help of the rest of the Visions for Equality team, organized this year's summit in the hope of bringing all of these partners in care together to continue exploring creative, collaborative solutions to the home care crisis. The speakers today will expound on some of the issues and solutions, and I'd like to extend a special welcome to them. Welcome to today's keynote speaker, Nancy Thaler, Special Assistant to the Secretary of Human Services, and also to Sally Kozak, Deputy Secretary, DHS, OMAP, and to Dr. Diana Plouffe from the University of Pittsburgh Imagine Different Coalition. In line with this year's theme, Partners in Care, the speakers will share information and perspectives and also provide resources, strategies, and strategies for advocacy and improving care at home. Thank you, and I hope you walk away with additional tools to partner in care. And if you missed last year's summit, you can still view the caregiver testimonies on Vision for Equality's website. So again, thank you and have a great day.
Charlotte, thanks so much for joining us. Thanks for that welcome. And thanks for all the support that IDS continues to send our way. We really appreciate it. Without further ado, I'm really excited and proud to present and to welcome Nancy Thaler, Special Assistant to the Secretary of the Department of Human Services. Nancy is going to give us a keynote. Thanks, Nancy. Let me make sure that you're all set.
Okay, can you hear me?
We can. All right,
Great.
It's all you.
Great.
Thanks.
Great. Thanks for everybody being involved in this effort. And I want to thank Charlotte for welcoming me and to give her kudos to Philadelphia County. Not all counties support advocacy organizations, particularly when they make trouble for them. So Philadelphia deserves a lot of credit for now decades of supporting visions and self-advocacy groups and for continuing to do that. So that is a really great thing. I'm going to talk about not your needs or the issue of nursing care. You all know what that is. I am working as a special assistant to Secretary Miller. I retired as the deputy secretary a while back in late 2018. And I've been working with the department and all of the offices to look at enhanced supports for families of children who are medically complex so that they can go home, stay home, and that the families get the support they need. It's a very complicated project because children who are medically complex get their services from so many different places, from early intervention, from education, very much from your Medicaid managed care organizations, some from Medicaid waivers, but not all. And it's easy for kids and families to fall between the spaces or the cracks in these systems. And it's hard to weave them all together to get some kind of comprehensive single approach. The secretary is very committed. In the middle of this, COVID happened and the department's attention and energies are very drawn by COVID, but she asked that things not be put on hold and that we continue to move forward, maybe a little slower as people are pulled off on other things, but we are continuing to move forward. There are a number of activities. We're looking at Medicaid waivers, certainly the issue of skilled nursing care and maintaining that service, licensing of residential agencies for little ones who are in there in transition, medical foster care for children who don't have families who can take them home. So lots and lots of different points to work on. But what I want to talk to you about, next slide, is how you can get people to pay attention to you. What I can bring to you is about 30 years or some period of time in state and federal government. And to share with you what people in Harrisburg need to hear in order to make something happen. The events that provide an opportunity for families to express the issues are very important, but they can't stop there, because all you will get are public officials who understand and are empathetic, but that doesn't necessarily lead to any action. This is not about who's in office. I've worked for 5 secretaries of Department of Human Services and for 4 different governors, and I also worked in the Bush administration in DC. You cannot predict which leader and what party is going to hear you and respond. It is exclusively a result of the efforts of people to get heard and create expectations. So I want to talk to you about that a little bit. So this is a slide that says they are, what are they all saying? This slide happens to have Secretary Miller and Governor Wolf because that's who's there now. They'll be there until the end of 2022, and then there'll be new people in their roles. But what I've seen over my decades of working in government is when little groups around the state have the same issue, and they all come to Harrisburg under the name of their local organization to present their needs, people are not necessarily saying the same thing the same way or on the same page. So if you're in Harrisburg and you are the governor or you are the secretary or even a deputy secretary, it's a cacophony. It's a lot of people who are sort of expressing the same need, but not necessarily asking, doing it the same way or asking for the same thing. And what that means is people just aren't quite clear what they should be doing. And so, next slide. This is a different picture, right? This is all the little groups who've converged together, and surprise, they're all saying the same thing, which changes the dynamic between you and the leaders in charge. Because when they're not clear, or there are a lot of different messages, they are accountable to everybody, which means almost nobody, and they and you get stalled in what's the message. But when everybody's saying the same thing, then the focus is on what do we do about this thing. And when I say, I've been working with a lot of the groups with visions for many, many, many years, for Imagine Coalition, PA families looking for nurses. And what happens sometimes is that all the little groups have a different name, a different focus, a little a message. Each group wants a relationship with the people in power because that's how your members locally think that you're doing something. But again, it leads to splintering and not one single message. An example of this in other venues are, think about labor unions. There are lots and lots of labor unions, but they all converge under the AFL-CIO, 50-some unions, so that their single message is represented by strong single spokespeople. Next slide. So that previous picture had a focus on the secretary and the governor, but there are more targets for your communication. Yes, there's the governor over on the right. Yes, there's the secretary of public welfare, but in that, or human services, but in that department, there are 3 offices that affect your lives. The Office of Medical Assistance, where all children's services are funded, the Office of Developmental Programs that also funds some children's services, but which you will look to as soon as your children turn 21, and possibly the Office of Long-Term Living also when your children turn 21. That's 3 different deputies, 3 different programs, 3 sets of regs, 3 different, lots of different waivers. And so each of them needs to hear one single voice. And on top of that, you have the House of Representatives and the Senate. We have the largest legislature in the nation, the biggest legislature, lots of people there that need to hear, again, one voice. Not lots of voices, but one voice. Next slide. I want to give you 2 examples in history of how it is that a single voice got systems change. So much of the history in Pennsylvania, in the nation, but especially Pennsylvania, is a history of litigation. People can't get heard or don't feel heard, and so a lawsuit gets filed. Now, sometimes the lawsuits are really necessary. I mean, the right to education lawsuit and the Pennhurst lawsuit were inevitable because government wouldn't listen, couldn't hear. And so the federal courts got their attention. It's a very long path to get needs met. 10 years, 12 years, it takes a very long time. If you can get elected officials, the executive branch of government and the legislative branch of government, to understand the need and formulate the solution, it'll happen faster and it will be a better solution because people can sit down together and create the solution. And I want to give you 2 examples. This one is from 1997. In 1997, actually, this effort actually started in 1995 when a new administration came in. It happened to be the Tom Ridge administration. And there was enormous frustration because nobody had left institutions for a very long time in Pennsylvania. There was almost a moratorium on closures, only under litigation. And families and advocates understood that all the money was tied up there. And if you could close some, and certainly people were better off in the community, that you could not only get people in the community, but you could release the funds to the community. And so on the right-hand corner of this, it says the multi-year planning group. This was a group, some leadership came to the department, to the secretary, and asked that a group be convened to put a plan together. And the Secretary of Public Welfare said, okay, if you put a plan together that is doable, that is actionable, that I can do something with, I promise to make an effort. I promise to take it to the governor. So this is a group of people, and you can see in this group, it included a lot of different people, a lot of different advocacy organizations, the county organizations, provider organizations, the ARC, and we spent a good year putting together something that was reasonable, that was data-based, that had a plan. And what you see is there were a number of recommendations in this plan, but one of them was to move 1,500 people who were currently living in institutions into the community. And y'all always wonder, plans get written and they get published and what happened to them. Well, this one got implemented. A lot of it got implemented. And probably the most dramatic is the fact that people absolutely moved from institutions. And the census when this effort started was 2,600. And within 4 years, the target was almost reached, 1,500 people. There were 1,534 people by that January. And so it is an example of everybody speaking with one voice, not using litigation, but engaging with the executive branch of government with a concrete plan that had detail behind it to make something happen. And that was a huge deal. But there were missing things in this. And one of the things missing was addressing the waiting list. Next slide. So the families came back and said, okay, that was good. There are a number of recommendations in that multi-year plan. You're moving on people leaving institutions, but the plan really doesn't address the waiting list. And so this time you can see the participants have a much larger number of families in the group. It was the counties, it was all these state organs, the ARC, the DD Council, the PNA, the Institute on Disabilities, a number of organizations, but also this time the families came back and said, we want half the group to actually be family members and people with disabilities. And so this group was a little larger with a much stronger voice, not just the execs and the presidents of associations, but families at the table. And they laid out a plan to address the waiting list. And there were a lot of components to this plan. Expansion of numbers, family support services, some metrics for the waiting list. But in the end, this coalition of people working with the executive branch of government did get change. And I have in the bottom the expansion of the Medicaid waiver over those years, which you can see is significant. It's bigger than the numbers that were in the original plan, because what this coalition managed to do was not just work collaboratively with the administration and not just put a plan together, but it was a large number of people speaking with one voice, and it put the waiting list on the agenda of the executive branch of government and the legislature, where it has stayed ever since. And so there's a waiting list campaign. Every governor that comes in knows this is an issue. And so there are two examples of lots of organizations putting aside their differences, and I can promise you there were great differences. When this waiting list plan was done, there were providers in the room who said, we can't grow that fast. And the families looked at the providers and said, if you can't do it, then get out of the way, we'll make it happen. You know, there were some real confrontation of issues and resolution of them in order to speak with one voice. And so there's great power in this one voice approach. And last slide, because I think I'm at my time. So I encourage all of the little organizations, Visions, the Family Group, Imagine Coalition, there's a group in Harrisburg, the ARC, the Disability Planning Council, the Health Law Project, is to coalesce around a message with the executive branch of government to expect solutions, not empathy, not understanding, but a plan to do something. And so here I am sitting in this, working for the secretary, inviting you to do this. I can tell you these two people are outstanding and wonderful and beyond empathetic and are action-oriented folks. But remember, they're only here until the end of 2022. There will be a new administration coming in again. And for all of you, it means starting again, hopefully during the campaign that goes on in 2022, to make clear not only what your need is, but what the solutions ought to be. And so with that, I'm going to end and pass the baton on back to, I'm not sure.
It's me again. Hi. Thank you so much, Nancy. You know, without fail, you sort of always capture the message and the heart of what we're trying to do. So I truly appreciate that. I'd like to, make sure everyone can hear me, because I know tech is what it is. So if we can get a thumbs up, I'm good. Okay. So I'd like to, again, you know, just remind everybody that this last year at the summit, And let me start here. Vision for Equality. I'll give you the quick history. Last year in 2019, Vision for Equality, which is a Philadelphia-based nonprofit that largely focuses on advocacy efforts and support services and being a support system for families who have an individual with autism or ID. They got wind of the fact that the shift nursing crisis, the home care nursing crisis and shortage, was really impacting families on all levels, including their population that they help. And that families were being really unduly stressed and stretched beyond what most people can handle. So they realized that this was not just a Philadelphia problem, this was a statewide problem, and they wanted to see what they could do and bring together a group of stakeholders from across the state and from across the industry. And in June of 2019, that effort started a bit of a movement, and it started to bring people together in the way that Nancy just described. I attended, my background is, I'm a former nonprofit leader, I am a special educator, but most importantly, I'm the mom of a medically complex 6-year-old boy who is trach vent dependent, G-tube dependent, requires an immense amount of hands-on care and medical monitoring. And while my husband and I are trained to do his care, and we have become, sort of junior nurses, junior pulmonologists, junior respiratory therapists, we can't do it all the time. It wouldn't be safe. It's not logical. We both have jobs, we have mortgages, we have other children who have needs, and we have familial responsibilities. What became clear to me through that time of, since we brought my son home on a ventilator, we were constantly battling to find nurses who were qualified and who were willing to handle and care for a child with such complexities in our home, which is where we knew he needed to be. And the agencies do their due diligence for them, for the power of the things that the nurses can do. The agencies have a limited pool of nurses that are coming into this field and staying in this field. So I walked into the summit last year to a room full of people who cared about that, and a room full of families who all had different types of needs and medical complexities and other responsibilities, but that particular issue was draining all of us in the same way. And it was so powerful, and it was almost overwhelming, and it was a wonderful day. Some of the takeaways that I think the folks in the room last year really got to. Next slide. And sorry, you can view, if you want to go back, Dana, we do have the official report from the 2019 Nursing Summit that's available to view on our website. We'll give these slides so you're able to click that. But some of the takeaways, the common caregiver issues, clearly were that there's a strain on families and we're unable to meet our other responsibilities. I had to leave my full-time job. We had nurses calling out and shifts open so often that I couldn't commit to a full-time employment. Many families report that they're looked over at their jobs for promotions. They're deemed unreliable because they're so often attending to the needs of their medically complex loved one, because the supports aren't there on the nursing side. We also found that across the board, we're all experiencing sometimes that nurses come to the home unprepared, or they lack the skills needed to deliver complex care in a home setting. And one of the other big takeaways was that accountability is low. With such a small pool of nurses who are willing and able to do this very unique work, if there is an issue, families are concerned and nervous about even complaining because they know that that nurse will just be taken off of their shift and put somewhere else. And the nurses, the agency's hands are a little tied because those nurses that maybe need some more coaching or training could ultimately just move to another agency. There's such a great need and there's such little supply of nurses that it's hard to hold the ones who aren't trained well enough to do the work accountable, and it's hard to hold the agencies accountable, and the families feel helpless in that situation. And the agencies, I think, sometimes feel helpless in that situation. And then the nurses who are working circles around and do, the folks who aren't quite trained enough are run thin. Caregiver input is also not effectively collected around nurse and agency appointment. There's a real lack across the board, we found, of getting real quality and usable family and caregiver experience in an input when thinking about the performance of the nurses or the performance of the agencies or the needs to make the situation better. I started to say this before, there is a general feeling of helplessness and isolation among caregivers of medically complex and disabled loved ones. And I know the family testimonials at last year's summit were really powerful. And living this medically complex life, I found myself just devastated hearing the stories of the other families. Just to put it into perspective for some of you who weren't there last year, we had one mom share a story about she has a very medically complex son who is active in his own way. He's an older guy now. I say older because my son is 6, but she and her husband are the main trained caregivers for their son, and they have so little consistency in their home nursing coverage that often the care falls only on them. And when that mother became medically complex temporarily, hopefully for herself, and started to have some really significant medical issues, it was an incredible strain because she was no longer to be one of those caregivers, and it flipped so that her family now needed to take care of her. And that was so taxing on her that she started to believe that her family would be better off without her. That given their situation, it would be better if she wasn't there. And she shared with us that she began to have suicidal thoughts because they didn't have the support in the home that they needed, and she was draining some of that support needed for her son, that they would be better off without her, which we all know is not the case. What we would be better off with would be a more comprehensive system of support to make sure that children like hers and children like mine and adults like her son are effectively able to be a part of their home with their loved ones and their community where they deserve to be. Next slide. One of the other big takeaways from last year was that there's a significant level of workforce issues when we're talking about home care. And for those in the room, this is probably no surprise. So some of the things that we identified was that from an education and training perspective, nurse training programs tend not to teach home care. There's no, curricula around what it's like to provide complex care in a home. And it is a very unique situation. And it requires a certain skill set that perhaps facility nurses and hospital nurses don't have to draw on. There's, a hope amongst this group that we can start building relationships with nurse training programs. I know there are some out there across Pennsylvania who are doing more in the world of training for home care. And I think it's really important to start, if we're going to transform the way home care is delivered in Pennsylvania, it's important to start at the beginning. So we identified this at last year's summit, and I've heard this throughout the year in different contexts, that the training, we have to start when nurses are coming through school. We've heard reports from nurses that they're actively dissuaded from going into home care. It's not a viable field. It's not where you do a career. It's not as exciting as the hospital. And with my miniature ICU in my house, I'm here to tell you it is. Critical care is happening in the home now. John Lincoln from Lincoln Home Care last year, I had the opportunity to sit at a table with him during a breakout session, and he said something that really stuck with me. And I'll paraphrase because I'm terrible at remembering exactly what people say, but he said, if you think about home care in 10 years, given the medical technology we have for supporting people in the home, hospitals are not going to look like what they look like now. So while the hospital jobs and the facility jobs may seem more appealing, more and more medically complex people are going to be able to be technologically supported at home going forward. And it's time for us to make sure that the workforce and the support systems that are needed to make that happen and to keep it safely happening are there and are robust. One of the obvious concerns and issues and frustrations around the workforce is the compensation and benefits. At this time, there appears to be no parity for acuity. So a nurse, there aren't official certifications or anything along those lines for nurses who handle trach vent patients in the home versus nurses who are doing lower acuity care. So we think it's important to start to distinguish those levels of care and the complexity and the critical level of care that's happening in homes across the state now, and identifying ways to make compensation catch up to that. There's a fluctuating income that comes along with home care work because it is shift work, and because patients happen to be fairly fragile when it comes, medically. So a home care nurse may have a patient that they're dedicated to, but when that patient goes into the hospital, their whole team of nurses are then without shifts. And they may be able to fill in on other patients, but that gets very difficult and tricky because once that patient comes out of the hospital, where did their care team go? So there's a lot to be said for, preventative medicine when it comes to shift care nursing, home care nursing, and the power that has to lower hospitalizations and lower rehospitalizations. Continuity of care is almost paramount to anything else. So we need to identify ways that we can attend to that fluctuating income that makes it feel like an unstable job. There's low access to health insurance. These healthcare workers who are providing critical care, complex care, hands-on care to folks in their homes often do not have access to viable health insurance options. So our healthcare workers don't have healthcare. And that is something that needs to be attended to on a wide scale across Pennsylvania. Agencies, again, are often small businesses, so they may not necessarily have access to the bargaining power needed to get the right rates that their nurses can buy into for health insurance. So finding ways that doesn't necessarily have to be direct pay, but there are compensation and benefits solutions that we need to identify and work toward to make sure that nurses who are coming into home care and are staying in home care because they feel as supported as the support that they're giving to their patients. Next slide. There are safety concerns. One of the things that makes home care so unique and such a more difficult job in many ways than a hospital or a facility is that every new home is a new work environment, and with it, it has complex differences. So my home is very different from Victoria's home, and it's very different from Catherine's home, and very different from Marisol's home, some of the parents you'll hear from today. Sometimes where a medically complex person lives is not necessarily as safe as perhaps where another person lives. We still need nurses for those folks, and those nurses need to feel safe and supported. So systems that attend to the environmental factors of home care, when nurses who are not walking into the same workplace every day or driving into areas that they're familiar with every day or that they feel comfortable in every day, we need to find ways to set up systems to support those nurses and to support those families and make sure they're getting the level of care that perhaps my family is getting. And one of the bigger takeaways that we were all a little surprised to find was an across the board reality is that there is a real stigma around home care from multiple lenses. From the nurse's lens, it's not viewed as a viable career, and they hear that in nursing school often. They hear that and they hear that from society. They certainly don't hear it from families with loved ones with medical complexities. They're our heroes. But what we've come to know is that home care is really undervalued by society. And if you think about if you think about a home care nurse, or perhaps before you entered this field or became aware of this issue, oftentimes what people imagine a home care nurse is doing is sort of just sitting perhaps with an elderly person or with a person who can't move around very much and prepping their medications and checking in on them from time to time. Whereas what the reality is that very complex people with very complex medical needs, behavioral needs sometimes, and mental health needs sometimes, deserve to live at home with their families just as much as anybody else. And the nurses are doing multiple jobs day in and day out. As one person's nurse or as multiple people's nurse, that one nurse is playing the role of multiple medical professionals, multiple types of interventionists. So it's unfortunate that this unique and complex role that home care nurses play seems to be misunderstood. And I think that one of the big takeaways from the summit last year was we absolutely need to attend to that stigma around home care and shift the view of what home care workers really do and the amazing support that they can provide. Next slide. After last year's summit, as Charlotte mentioned, Vision for Equality felt so strongly that this was an issue that needed to continue to be addressed. They created a program around this called PA Families Need Nurses Now, which I am the program manager of, and you got to hear about some of our our advisory council members. Some of our goals are to provide ongoing peer-to-peer support, education, connection, and advocacy for families in Philadelphia and Pennsylvania caring for loved ones with medical complexities. Next slide. We want to empower families to be active participants in all processes and planning that impacts our access to skilled nursing and other supports at home and in the community. Next slide. And we strive to partner with providers, policymakers, other stakeholders to create lasting systems level changes that guarantee everyday lives to individuals with medical complexities in Philadelphia and across the state. And this sort of gets back to what Nancy was talking about. We have, over this last year since our inception, really just sort of explored the landscape of who's doing what. Who's already interested in this issue? Who's already impacted by this issue? What organizations are out there? What are they saying? And one of our main focuses has really been sort of identifying who else is moved by this issue and trying to come together and unify our work. So we've been really fortunate to connect with other groups and organizations like the Imagine Different Coalition, Little Lobbyists, the PA Elks Home Service Program, Pennsylvania Health Law Project, Beata's Hearts for Home Care, the Technology Assisted Children's Home Program through DOH, Disability Rights Pennsylvania. These are all groups that are actively pursuing solutions to this same problem. And what was so interesting is that, after the summit last year, when I started to figure out who was who, and I thankfully fell in the lap of Nancy Thaler very early on, who pointed me in the direction of all these wonderful organizations. We were all in this same place where we were trying to find each other, and we did. I think that some really amazing work has happened in the last year because we've all started to combine forces and really try to tackle these issues together with a unified voice, with grassroots efforts, and with family input. Next slide. So just to give a quick overview, I know I'm getting close on time. I'd like to build on a little bit of a bio break for everybody. So I'll go quickly here. There is state level attention happening to this issue. You will hear about the OMAP Shift Care Initiative, which Deputy Secretary Sally Kozak will hop on later to give us a summary about the work that they've done over the last year around this issue on the peds side, on the pediatric side. I'm going to jump down one. ODP has been expanding their focus around individuals with medical complexities. including the, with Nancy Thaler having a position where she's able to sort of focus and hone in on some of those issues of medically complex individuals across the state. I don't believe that there's ever been a position quite like that before. So it's really evident that folks at DHS recognize that this is an ongoing issue, and it's something that's impacting families and their abilities to live in the community. There was also an interesting, there was a House resolution in Pennsylvania, HR 501, which is linked on the slide, and you can surely Google, where the Pennsylvania House actually adopted a resolution specifically around the resolving the importance of shift care workers in homes across Pennsylvania. I won't get too into that, but it's just sort of, it highlights again that we're at this precipice where the state and local groups, the state, we're all hitting this point where we recognize something really needs to change, and that the workers that are doing the work are incredibly valuable. Next slide. There is also national attention around this issue. This is, the PA Nursing Summit, so I won't go down the rabbit hole too far here, but I'll keep these links in the slide. I hope everybody will check out some of this information. Lucille Packard Foundation is doing some amazing work collecting research and sharing data and hosting webinars around home health care for those who are medically complex, for care coordination for folks living medically complex at home. One of my favorite webinars that they have put out in the last year, I think was in October of last year, the next steps to improving home health care for children with medical complexity. So clearly, this isn't just a Pennsylvania problem, this is a national issue, and there's some really amazing data that came out of that webinar that supports sort of what I was saying earlier, it goes into the unfilled shifts and how that increases hospitalizations, et cetera. So I encourage everybody to check that out. Center for Healthcare Strategies is putting out wonderful information as well, really targeted information around complex care and in home care in particular. There's a great, again, I linked on this slide, to toot the horns of what's happening here, incorporating community voices to advance complex care. So once again, it seems like not only here in PA, but perhaps nationally, we're recognizing that the folks in the community with the lived experience are really paramount to maybe all other input at this point for how we're going to really advance complex care and support medically complex and disabled individuals in their community. There's also, one of the presidential candidates, Joe Biden, is very interested in healthcare issues around disabilities and medical complexities. Certainly, he has a vested interest in ACA and the way that that expanded Medicaid. And one of our PA FNNN Advisory Council family members, Victoria Salerno, had the opportunity to sit down with him and two other families recently when he visited Lancaster, and she got to explain exactly how the issues in home care have impacted her family so devastatingly. Next slide. So what's next? What came out of the summit last year was this momentum. We all felt it, everyone who was there, and I find myself in meetings with all different levels and all different organizations, and anybody who was at the summit last year talks about those family testimonials. So as a family member, I want to say, thank you to all of the groups and departments that have been so open to embracing family input this last year. And what's next is that we all need to stay together on a track to transform home health care. We can do that by bolstering the home care component in nurse education programs. We can do that by stabilizing the work for the nurses. Home care nurses need healthcare. They need pay parity, and we need to really shift that view and that value we put on home care workers. Next. We need to recruit and retain. There are creative ways that we could attract highly skilled nurses into this field. This is community work. This is high need field. There is a potential for loan forgiveness for nurses who commit to a certain number of years in home care. We can expand professional development opportunities around complex care in the home. There are so many things that wouldn't necessarily be a huge lift, but could really start to change the landscape of home care. And we, of course, have to create a culture of value. We have to continue valuing family input, can increase the level of value on family input, and certainly increase the value that we place on the home care workers that are saving the lives and sanity of families across Pennsylvania. And that's, that sort of sums up what's been happening over the last year. PA Families Need Nurses Now is available to answer any more questions. There's a number of groups that are doing work across the state, and continued support for these groups is going to be imperative to move this work forward. All right, next slide. So next up we have Sally Kozak, who I do see is here. Hi, Sally, can you hear us? And can we hear you? It looks like Sally's audio is connecting. What I'd like to do is take a 5-minute break and well, here's what we'll do. We'll do a couple of questions from the chat box. Amy, is there I saw a question pop up. Do you want to let me know? Maybe I can answer that really quickly while
So yes, we did have a quick question, which was, would legislation adding a requirement for the home care component in nursing training programs be a useful means to increasing population of trained individuals?
Sure, it sure could. I think, and this is, I entered professionally into this realm only last year and had a crash course in what department does what. Walking into the summit last year, I didn't even know what OMAP was or what ODP was. ODP could have been a lost member of the Wu-Tang Clan. I didn't know. But what I've learned over this last year is that legislation takes a long time. Legislation can take a long time. Regulations can take a long time. So I think the short answer is yes. There certainly could be regulations around training programs, making sure that they include a home care component. I think that on the immediate level, the building of relationships with nurse training programs and the awareness around the need and the education of the educators is really, really key right now. I don't know that those who are running nurse training programs or teaching in nurse training programs necessarily have their own experience in home care, so they don't recognize how much the field has exploded. So I think, groups like mine and others in the state who are identifying ways that we can support training programs and ways to help them expand their understanding of home care is probably where we start. So I'm just going to double check and see. Sally, can we hear you now?
Can you hear me?
We can. Okay, so I'll stop talking because Sally's way more exciting than me. I'm really excited. I'm really pleased that Deputy Secretary Sally Kozak from the Office of Medical Assistance Programs is able to join us today and tell us a bit about, and Sally, I will say, I did mention the OMAP Shift Care Initiative earlier, but I didn't get into any details because I wanted to let you talk to the crowd about that project that just wrapped up for you.
Okay, great. And I apologize. I was on the video and I don't know what happened. My Zoom keeps cutting out, so I decided to just call in and hopefully my phone doesn't cut out. So
we're all having a couple of connection issues, so no worries. Thanks so much.
You're welcome. So, Megan, thank you so much for inviting me to talk to the group today to share what it is that we're doing within the Office of Medical Assistance program as it relates to shift nursing for children with complex health needs. So first, let me introduce myself and give you a little bit of background about me. I'm Sally Kozak, and I am the Deputy Secretary for the Office of Medical Assistance Programs in the Pennsylvania Department of Human Services. And so my office is responsible for administering Pennsylvania's Physical Health Choices program. And the Physical Health Choices program is our mandatory Medicaid managed care program that covers medical services and prescriptions for those who are eligible because of their income or disability. I've been in this role for going on 3 years now. I had been with the state for a number of years, way back when. I'm not going to tell you how long ago. And we were bringing up the Health Choices program at that time. So I've been involved with it since its beginning. I'm a nurse by training, and I spent a number of years working in surgical trauma. And when I left hospital-based care, I moved on to do some agency work until I decided what my next career move, so to speak, wanted to be. And because of my ventilator experience, I was often asked to do residential care for children with complex needs, especially those that were ventilator dependent. And then when I finally came to work for the state, we implemented health choices, and we had some waiver provisions in place that began to allow children and adults that were complex to move into the community. At that point in time, though, it was just a handful of children. I mean, the technology had not advanced to the point where it is now that it was easy to move people with ventilatory needs into the community. I mean, back then, the ventilators were as big as small washing machines, and now we have people walking them around with them in backpacks. So technological advances have definitely allowed expansion of that. And just to give you a sense, right now we have about 6,000 children who receive some level of pediatric shift nursing in a home setting, and about 600 of these children are considered to have complex cases, which, like I said, when we first started doing this, it was less than 2 handfuls. At the time that I left the Commonwealth, which was probably about 16, 17 years ago now, there were issues with ensuring coordination of care for these complex children, and there were also issues with pediatric shift nursing. There's nursing shortages, and home health nursing doesn't necessarily present a career track and for folks. And I've said from my own experience, it's not the first thing that jumps to my mind when I first got out of school and said, here's where I want to go. So I understand some of the reasons behind some of the shortages and some of the difficulties associated with attracting individuals. So we had those problems years ago, and 17 years later, I have an opportunity and the privilege to come back and sit in this chair. And within my first 2 weeks, one of the first issues that comes across my desk is a complex case that has frequently missed shifts. I literally banged my head against my desk. I said, I can't believe it. In all these years, we have not made progress in addressing these, and the issue has only gotten larger. So that, for me, was really the impetus to say we have to do something about this. I mean, in particular, for one of the first times ever, we have a nurse, a clinician, sitting in the desk in the deputy's chair. And so if it wasn't going to be me that decides to try to tackle this, I'm not sure who would. So with that, I decided to go ahead and take a look at how it is that we can change the way that these children receive care. I wanted to start a conversation about the best ways to provide whole person integrated care to children with complex medical needs. And when we are talking about pediatric shift care for these children, we need to define whole person integrated care differently than we do for other populations. In the context of these children, it's not only addressing the clinical needs of the individual, but it needs to address all the needs of the child's family, the team of caregivers supporting them. And this includes the nurses that go in and out of the home, the nurses that are at the day program, the patient-centered medical home staff, and in some cases, even the staff at the NCO. For me, it was really about how is it that we move towards seamlessly integrating the entire ecosystem or environment that surrounds the child that's receiving services. It's all encompassing. Those folks are necessary to support the child in living their fullest life. And so that's what I mean when I talk about integrated care for children with complex needs. So one of the first things I did was develop a series of pediatric shift nursing workshops that brought together representatives of the physical health managed care organizations and nursing organizations, or home health agencies, I should say. That's the first time that those folks had really ever been brought together in a room, and it was unclear whether or not they would even really talk with each other about the issues. And so we held our first workshop June 20th of 2019. And I was really amazed at the level of participation. I mean, we had all the major agencies, some of the smaller agencies. It was a full day of conversation, and we walked away with a lot of good ideas and directions in which to go. So one of the takeaways from that very first meeting was the identification of 5 key areas where everybody felt work was needed. And so those 5 areas formed the basis for work groups that we eventually formed. Those work groups met over the course of the next year, about biweekly, up until our final workshop, which was just held last week. And so the 5 work groups that we had were focused on service coordination, nurse-caregiver relationships and co-training, discharge and transition planning, physical and behavioral health coordination, and nurse recruitment and retention. So what I want to do is talk a little bit about each of the 5 work groups and some of the recommendations that they will be making to us, and then to just briefly talk a little bit about what the next steps are. So the service coordination group carefully considered each of the functions of service coordination and who is best situated to take the lead role in carrying out those functions. They looked at guiding principles to inform each step of the service coordination process, including the importance of trust. They are proposing some alternative models of service coordination that would assign lead roles to the elements of screening and identification, outreach and information sharing, assessment, individual planning, case management, assisting accessing service and supports, and monitoring and follow-up and oversight. Additionally, this group discussed the need for a uniform assessment tool to identify each child's clinical and non-clinical needs, including finding the right mix of skilled and unskilled hours needed to meet a child's clinical needs. Right now, we have each of our managed care organizations doing something separate in terms of assessing what the needs are. And many of the home health agencies, well, they are using some level of standardized tools and assessments. They are not uniform across the board, and they typically generally just focus on solely the physical health needs, the clinical needs of the individual. There are exceptions to that, but it's not as widespread and as comprehensive as it could be. So that was the biggest recommendation that came from that work group. The work group that focused on behavioral and physical health care integration are proposing an integrated care plan that would allow the child's physical and behavioral health MCOs to coordinate with one another to ensure all the needs are met. We've already been doing some work with this with our physical health and behavioral health MCOs for some of our high-risk adult populations. So, for example, people with serious persistent mental illness. And so there is foundation for this already. And so we anticipate that that's something that we should probably be able to move forward with in a short amount of time without difficulties based on some of the experience we already have. This work group also proposed incorporating mental health awareness into the nursing agency's portfolio of trainings so that nurses are more comfortable working with children and families that have behavioral health needs. We recognize that lots of times the folks that are going into the home to do some of these services have probably a little bit more of a critical care type background because of the ventilator needs. And so I know from my own experience working in those types of settings, you really don't have a significant need to focus on the behavioral health piece because that's usually taken care of by others within the organization. So that is clearly an area where there may be a skill gap and some training needs as well to help make people feel more comfortable in accepting these types of assignments. The Transition and Discharge Planning Group developed a recommendation for a uniform discharge checklist that accounts for all the critical areas to ensure a smooth transition to the home. They also made some recommendations around co-vending situations, and co-vending situations are where a single family is served by multiple nursing agencies. Some of the gaps they identified there were ensuring that everybody has access to all the information needed to provide seamless care. There were some gaps in how information is recorded among multiple agencies. And so one of the recommendations that was really exciting to me because it falls under my area to monitor is the facilitation of an integrated care plan through Pennsylvania's Health Information Exchange, which is through our eHealth Authority. And that's particularly exciting because the eHealth Authority has already started work on what a shared care plan would look like for home and community-based and behavioral health services. So again, there's a foundation there that we can build on. The group that focused on nurse-caregiver relationship and co-training discussed the importance of what needs to be in the care plan so that it accounts for all the needs of the child and the family, including the non-clinical ones. The goal with that is to make sure that nurses and families are clear on expectations when beginning their relationships. We often hear that is sometimes a point of breakdown when expectations from each side are not being met. The group also recommended the creation of family councils, which would be made up of family member representatives, and these councils would serve as a liaison between families and the agencies that serve them, and they could provide assistance and peer support to new families. They also developed a recommendation about the creation of a training portal that would be available to all nurses providing skilled services in the home setting, as well as for the family members of children who receive these services. And this would go a long way to help ensure consistency in training and accessibility for these highly specialized training resources that are not always widely available. And then there was a work group that was focused on nurse recruitment and retention, which sent a survey to all registered nurses and licensed practical nurses in Pennsylvania, looking for insight about why they chose to or chose not to go into the field of pediatric shift nursing. And I know that information and findings from that is going to be shared with the group a little bit later. So I'm not going to talk about that in detail. One of the recommended strategies that did come out of that work group, though, was to engage nursing schools to help highlight this career path during a nurse's education. And there were also some recommendations that came out from the group about regulatory changes that could be made that would support nurses already in this field. So those were the 5 work groups, and those were the recommendations that we anticipate they will be making to us. Over the next several months, we will look at the recommendations. We anticipate that the Deloitte, who was the contractor that was helping us to support some of this work, will have a final white paper that summarizes everything that happened over the course of the past year, and that summarizes the recommendations and helps prioritize them based on some voting that's currently going on out there among the various members of the committee. And we anticipate they will get that to us probably mid to late September. The findings, or what we're calling a white paper, will be shared within the executive level at the department, where we will have some ongoing conversations about how it is that we can operationalize these, and what we can do immediately and what it is that we can do in the long term to begin to transform the way we think about the care that we provide to children and families with complex needs. So that's where we've been in the past year. Those are the next steps. It's really just the beginning for us. I mean, we recognize that there are many aspects, many issues that still remain unaddressed and unexplored. And so part of the conversation, in addition to how it is that we operationalize the recommendations that we're going to receive, what it is that we do next. And with that, if there are questions, I'd be happy to answer them.
Thank you so much, Sally. We really appreciate all that you've shared with us and the work that you do on behalf of families and nurses as well. There are a couple questions that were entered in the chat. One was around accessing the information that you shared around the work group. Is there a place that some of that reporting out is housed, and where would they go to access that?
You know, that's a good question. We've shared some draft materials with the participants of the work group, and we've had some internal conversations about how it is that we get that information out more broadly. I don't have an answer for you right now, but I will certainly make sure that that information is shared on how it can be accessed.
Thank you. One of the other was a comment and kind of just bringing back us to the focus of that, you know, as a nurse that does both facility and home care, it's very difficult to fill shifts with quality nurses. Though there are agencies that provide training for nurses, the nurses may be very comfortable with their current caseload and not necessarily willing to take on new or complex cases. Home care nurses are working various shifts in 1 week. When a nurse takes a vacation or a sick day, there are no available backup nurses. And families find themselves having to fill those roles or on FMLA or not getting enough rest prior to work. There are families using 2 to 3 nurses at a time and still not receiving skilled nurses. Families are going out of state to place clients in facilities because of the lack of admission in the state. So I think it's just a powerful synopsis of the critical need to address this. And I think you touched on some of the efforts, but we still all know that there's work to do. One of the other questions, go ahead.
I just wanted to say there was some really good conversation, and I have to say, and I apologize, I didn't say this in the beginning. Well, the very first meeting included just the NCOs and the home health agencies. And again, that was because we weren't even sure that they would really talk to each other or if they would just all sit in a room in silence. As we moved forward, we included families in all of these conversations. So there was some really good conversation that came out of the work group that was focusing on nurse recruitment and retention about beginning to have conversations and explore new models of care. And one of the conversations that came out is you know, especially with the public health emergency, the COVID pandemic, you hear more and more discussion about pods. You hear about school teachers doing pods, daycare programs doing pods, nursing facilities doing pods, and so one of the pieces was, why isn't there a pod? Why aren't there a group of nurses that are dedicated to a group of individuals, whether it's regional or what it looks like, that can cover for each other and that can rotate? And why aren't there potentially payment structures that encourage and support that? I said, you know, I've had jobs over the years where I do job sharing, and so if I want to take 3 weeks off for vacation, that's fine, because the people that I job share with are going to work 3 weeks nonstop, and it all works out. But yeah, with home health, we tend to say, well, with nursing as a whole, but in home health in particular, here's a shift. And so there was really exciting conversation about the need to begin to look at different ways to do staffing. I mean, this is a different environment, and so I think there's some opportunity for creativity there. And that was I just found it a very exciting conversation between the families and the home health agencies as that started to take place.
Thank you, Sally. And we've had other comments about the complexity of their personal situation, and wondering how more families can be connected and have access to the information, because it's wonderful to hear that families are being connected and a part of the work groups and developing going forward. And at Vision for Equality, we have a saying of by families and for families. And that's so important as we go forward, that they continue to be not only a part of the conversation, but have a seat at the table going forward with all of this. So how could families get more connected? You know, one of the ways I would like to answer it is getting connected with our PA Families Need Nursing Now. But from your perspective, working with these work groups and your plans to create more pods going forward, how would other families across the Commonwealth get connected with that work?
You know, there are a few avenues. We have our Medical Assistance Advisory Committee. We have what is called the Consumer Subcommittee. And we do have representatives from some children with complex needs on the committee now. But that is certainly a mechanism for people to get involved and help broaden the conversation. Our managed care organizations also have some advisory committees, and so I would encourage people to reach out to them. We and they are always looking for consumer representation to address the issues. We post a lot of our stuff on our website. I would encourage people to look at that. It announces oftentimes the meetings and initiatives that we have in place, and if there is a particular individual that has interest in being more closely involved, I would certainly encourage you to reach out to me and let me know about that interest. And again, we continue to work with the various organizations sharing information, and so to the extent that folks are connected with one of those organizations, the information becomes available as well.
Thank you, Sally. I'm going to use this opportunity to kind of wrap up the question of and this was posed to all panelists. So panelists, you can also see the chat. So as you prepare to speak later, you might want to consider framing what you respond to this in the future. But around the question of what entity or agency or administrative arm is truly responsible at the end of the day for the oversight and accountability for nursing agency performance and response to this critical shortage and crisis that families and individuals with disabilities are facing currently. So I'll pose that to you, Sally, at this time to answer, and other panelists can, if you want to speak as well to this later.
Yeah, there's no one single answer for that. Home health agencies are licensed by the Department of Health within Pennsylvania. Department of Health has their own set of requirements around that. Agencies have some level of responsibility to be Medicare certified, depending on what type of services they're providing, especially if they're getting paid by Medicare. They have to follow those requirements. Within the Medicaid program, they have to be an enrolled provider, and so they have to follow those rules. And then there are any number of credentialing requirements that our physical health managed care organizations have in place. So it's complex as to who it is monitors and oversights, because different groups have different levels of responsibility. At the end of the day, OMAP, my department, is responsible for ensuring that our managed care organizations provide all medically necessary care to their members. And clearly that includes the children with complex healthcare needs. We do monitor. We have several reports that are dedicated to missed shifts, as we call them, the missed shift report. We have processes that we have in place to monitor most specifically the case management activities that are happening with these children, with a focus on those, what we call those difficult cases, the ones that have a high rate of missed shift nursing for whatever reason. So at the end of the day, it's OMAP that has responsibility for ensuring the provision of services for these children and their families.
Thank you, Sally. Megan, at this time, there's no other additional questions in the chat.
I did see one, just quick, someone did, Erin asked, she wondered if there were nonprofit nursing agencies, and if there aren't, why not? Beata, in the last couple of years, actually transitioned from a for-profit entity to a nonprofit entity. I don't have a lot of information around that, but that's something I'd love to explore with them, and that PA Families Need Nurses Now plans to talk about with them, perhaps add something to our blog around what the impetus of that was, and how that's improved or not improved their ability to service clients. Other than that, I can only say that I believe that, you know, several years ago, perhaps before my son was born, the state of Pennsylvania moved into a managed care option for the provision of Medicaid for medically complex individuals in the state, and that there is some restriction in that from a federal level, from a state level, in terms of how that can be implemented, particularly, you know, that we're a state that's an agency model. But that's not to say that I would say, and perhaps Sally, correct me if I'm wrong, that's not to say that agencies could not necessarily be a nonprofit and still be a Medicaid provider. But Beata is clearly doing it. So it's something to certainly, as folks in the room are thinking about solutions, it's a model to think about.
Yeah, there's nothing that prohibits a nonprofit provider from being a MA enrolled provider. So, Megan, I apologize. I do have to run for another meeting, but I want to thank you for providing me with the opportunity to speak with everyone, and thank you for the follow-up questions. And clearly, if there are additional conversations or comments that folks want to share with me, feel free to reach out to me directly at the department.
Sally, thank you again so much for taking the time to be here. I know, especially in this time of COVID, your department is overrun with needs. So we really appreciate you taking the time. We appreciate the work your department is doing and the strategies, your perspective and the strategies that are looking promising to help transform home health care in PA.
Well, thank you, and you're welcome. You have a great rest of the day.
You too. Take care. Thank you so much.
Bye-bye. Bye.
So we're at 11 o'clock, and on our agenda, next up we have Diana Plouffe, who is from the University of Pittsburgh, retired lucky lady, and she's also a steering committee member of the Imagine Different Coalition. She's going to give us some information now about this nurse survey. I want to make sure that I give Diana full privileges for sharing, but Diana, I'll get your video going. We'll be able to see you in a moment. And let's make sure we can hear Diana. Diana, are you there?
I am here. How are you?
Wonderful. Hello. Without further ado, please take it away with this great information.
Well, before we start, I know that on the agenda there was a chance to take a break for personal needs. Do you want to do that for a few minutes?
Sure, we could do that. I think now's as good a time as any. We actually will possibly have some time at the end, but let's do that now. I think that's a wonderful idea, Diana. Let's just take 5 minutes.
Great. Just flag me when you want me to start, because we have plenty of time, I think.
So my clock says 11:03. We'll come back on at 11:08. We'll just do a quick break. Everybody run, grab more coffee, and then strap back in.
Great, thanks.
Okay, I think we're going to come back now. Diana, I apologize. You know what? We did have a few polls that we wanted to throw out there to the group, just to get an idea. Of who folks are in the room. We're curious which one of your roles brought you to the Nursing Summit. So you will all see a poll pop up on your screen. I'm going to allow panelists to vote as well. So we'll just take a few seconds and allow people to answer this question. Which one of your roles brought you to the Nursing Summit? I am a parent or caregiver of someone authorized for in-home nursing. I am a parent who is authorized for in-home nursing. I am a home care nurse. I work for a nursing agency. I work for an insurance company. I work for a nursing school or training program. I work for a government agency or department that serves the disability population. I work for a non-government agency or organization that serves the disability community. I am or represent a legislator or policymaker or other. And we'll take about 10 more seconds to do that one. And then just one quick one. We wondered, did you attend the Nursing Summit last year? We're curious if we have some repeat attendees. So here's a quick poll. We'll only do this one for about 10, 15 seconds. Did you attend the Nursing Summit last year, or are you arriving to us fresh and new? Your options are yes, no, or I don't remember, because given 2020, I wouldn't be surprised if no one can remember 2019 at this point. If you, going forward, if you fit into one or more category of the polls, it's okay to just pick the one that's the most relevant to today. But it's okay if you missed that. All right. We'll do one or two more polls going forward. It looks like we have about 25% of our participants were here last year, and almost 75% of our participants were not at the summit last year. So this is wonderful to see that we have so many new folks joining us. And Diana, I'm gonna stop polling folks and let you get to the real interesting and well-reviewed data that you collected.
Great. So wonderful. So am I on now? You're passing the baton to me, Megan? Okay, I'm assuming you're saying yes, you're muted, so I'm assuming you can hear me.
Yeah, it's all you.
Great, all righty. So this is a survey of nurses who currently or have formerly provided in-home nursing in Pennsylvania. And I'm so delighted to report that this was a very successful and shared project of the Imagine Different Coalition and the Pennsylvania Office of Medical Assistance Programs. It was a wonderful collaboration, and happy to share these results to any interested folks. So particular thanks to Gwen Zander for her assistance in this from OMAP. Okay, next slide now. Okay, I wanted to let you know that we distributed the survey in the months of March through June of this year, and then we wanted to reach all nurses. However, COVID may have interrupted that process a bit. We did receive 1,471 responses. Of those, the respondents who met criteria, which means that they actually did provide services or are currently providing in-home services in Pennsylvania, and those who met criteria in terms of completing enough of the survey got the number down to 841. So that's the group that we're thinking about when we look at this. And in addition to that, just sort of thinking about how the distribution of respondents, 45% of those who responded have a historical experience providing in-home nursing care to families in Pennsylvania, and 54.8% currently do it, which is a sort of fairly even distribution. But if you look at the training level of those who did it in the past, most of the respondents were RNs and a few were LPNs. And currently, those people who are working in home, a majority of them are LPNs. So that's something to think about. You all may be wiser about interpreting this than I am. I'm not sure if that has to do with recruitment issues or other matters. So you exercise your wisdom about interpreting that. Okay, next slide, please. And these are years of experience, and I did sort this out by former and current to see if there was any difference, and there really isn't a difference here. You can see that a majority of nurses who are doing this work or have done this work are very experienced nurses, 67% or so on average. This question did not ask how many years of experience in in-home nursing these people have, but you may be able to tease that out with some future slides. So we don't know. We can't say that they've had more than 10 years or more than 8 years of experience in in-home nursing, but they clearly are an experienced group. Okay, next slide. This survey was designed with a particular interest in understanding or getting some information that might inform recruitment and retention strategies. So we wanted to find out what first interested people in providing in-home nursing care. And so these are the reasons that people had selected among options. And there were work features that are particularly interesting or attractive to folks, and that was flexibility, which is the first option here in terms of the reasons. And if you look at the fourth, autonomy is another feature. So there's something about the nature of this work that those people who do it like these particular work-related features. The other two high reasons were to help children stay at home with their families and to work with families. So the folks who do this work or were attracted to this work were interested in this environment and in the meaning and the purpose of this work so that children can grow up with their families. Okay, next slide. We asked current nurses what are their plans to continue to get a feel for anticipating need. And you can see that a majority of nurses see this as their career. 66% of those who responded see it as their career. So folks who do this, think about this long term. The flip side of that is about 34% of those respondents plan to leave this particular area of nursing work. So that's something to be mindful of in thinking about nursing shortages going forward. Next slide. We wanted to know to what degree respondents liked various features of the work they do. And so we asked them to rate these on a scale of disliking a great deal to liking a great deal, and these are the percent responses for each feature. So you can see the features along the bottom, the x-axis, helping a child with complex medical needs have as regular a life as possible, being a key resource to families about their child's health, using skills to make clinical judgments about child's health, working with families to plan for their child's care, and having long-term relationships in my role as a nurse. The majority of people liked these features a great deal. So people who do this work like this work. And you can see in that following slide, next slide, these are some additional aspects of care. Having flexibility over the shifts and hours worked is a big attraction. Having autonomy, just similar to the features that attracted people to it. Helping families ensure a safe home environment for the child, and helping families transition from hospital to home. So overall, you can see that, again, people who do this work like these features about the work. Alrighty, so even though they may find some things challenging, and this was our attempt to get at that, we asked respondents to, on a scale of 0 to -10, to what degree do these features negatively impact your satisfaction? And you can see we asked about neighborhoods that feel unsafe, families who don't understand my role, homes where uncomfortable things happen, limited space to provide care, and language barriers. And the longer, you can see along the left-hand axis, these are descending numbers. The scale was from 0 to -10, with -10 meant extremely, an extreme impact on negatives, on dissatisfaction. So you can see the longer the bars on this, there's 2 slides on this, have to do with that sense of safety and discomfort with some things that happen in people's homes. This slide also asks those questions, and you can see just the longest bar looking far to the 4th one in, no pay when the child is hospitalized, is the most negatively impacting feature of the work among the options that they had to respond to. Feeling undervalued by employer and no pay when shadowing to learn a child's care are also negatively impacting, more than getting last-minute emergency assignments, receiving work schedules late, and insufficient notice about changes in care plans. Okay, thank you. Now we asked folks to rank on 8 items as to which aspects of the work were most important to them. The top 2 were doing meaningful work and pay, sufficient pay, sufficient pay. I think we just really gave them that as the option. And you can see those 2 are clearly critical to the feeling of what's most important to the nurses who do this. And that's followed by a good match in assignments. It's a fit between the nurse and the family and child, and the importance of continuity. There were a number of comments about the benefits of being able to be with the same child and family over time. And then those that were of ranked less often as important were agency support, benefits, opportunities for growth, and this is getting enough assignments, the last item here. Okay, next slide. Now we asked the survey ended with 2 open text questions. One was, what would you indicate as motivators to continue or return to work in pediatric nursing in-home care? So people wrote in their open text options, and we had more than 1,400 items in this sort of open text, this particular open text question. After coding them, I selected those coded items that appeared 10 or more times. So these are the ones that people said most often. And you can clearly see that pay and benefits are really high on this list. It's sort of 1 out of every 3 or 4 people indicated those as really important features to keep them staying. And pay, Megan did such a beautiful job sort of elaborating everything on this, about this data ahead of time. So I have to thank her for that. All of the descriptive comments that she had made in her presentation really reflect this data overall. So pay really covers a variety of things: consistent pay, pay increases, differential pay for shifts, etc. And benefits were both healthcare benefits and things like part-time, vacation time and that sort of thing. Okay, so that was motivators to continue or return to work. And then the last slide, which follows this one, is, you know, a question about what would attract, what would you say would attract new nurses? And I think the actual question was new good nurses to the pediatric home health field. And again, we had about 1,200 plus responses to this. And those that after coding appeared more than 10 times are the ones you see here. And pay was clearly the most often made suggestion about attracting nurses, and the discussions that related to that had to do with if nurses are currently working in other positions, the pay here has to be attractive enough for nurses to consider changing their the work that they do, and parallel to that would be our benefits. So those consistently are sort of high work-related features that nurses are reporting that they need. The other thing I really, so you can see, and then following that, or working with a good agency, a supportive agency, flexibility, having some control over hours and having enough hours, opportunities for education and growth. And this next one, I apologize for the typo here. This is market the option of in-home nursing and its value. Megan earlier talked about the stigma associated with this. I'm not sure if you use that term or not, but within the field, evidently, this is not seen as a highly valued option. There are people who are not even aware of it as being an option. So the suggestions that Megan had indicated in her talk about making this information available early in training and working on ways to increase its perceived value would be things to consider in terms of attracting new nurses. And the others, good family, being respected and valued both by family and by nursing agencies are less often, but still fairly often were mentioned, as well as safety in the home and neighborhood, having a sense of purpose, the ability to work autonomously. And there were a number of comments about either getting support for reimbursement for travel time or being close to home. Evidently, traveling distances to support families is a feature that is of challenge to nurses. And that's what we've learned thus far. So Megan, I don't know if there are questions. I'm happy to entertain them. I really do think that we could have flipped our presentations because you so beautifully articulated these points and the action implications associated with them.
Yeah, it's also interwoven. I think that the conversations almost circle and intertwine so well, because it really is, this is the truth. This is the data. This is the experience. I'm so appreciative to you for presenting this, and to the Imagine Different Coalition and the Office of Medical Assistance Programming for teaming up and doing this survey. I had got to contribute a little bit in the creation myself, yeah. And that partnership between Pennsylvania Families Need Nurses Now, Vision for Equality, Imagine Different Coalition has been such a boon to, I think, to the work that's being done. We do have a few questions.
Mm-hmm. Yes.
Amy, I'll let you jump in there.
Thank you. And thank you, Diana. This was very impactful. One question is, are pay increases for pediatric home health nurses dependent upon insurance reimbursement rates to home health agencies? And if so, what limits are currently impacting pediatric home health nurse pay and benefits?
Well, I would love to be able to answer that question, but I can't. I think that's a question that needs to be posed to someone who really understands Medicaid reimbursement, et cetera.
Thank you, Diana.
Yeah,
one of the other questions, no, that's okay. from the survey, and we did put it to the person that posed it, but just to inform all attendees, the total results from the survey will be posted on the PA Families Need Nursing Now website by the end of today, and more information on the Imagine Different Coalition and the work of this survey as well. One of the questions here, and I'm not sure if you can speak on this or if it came through in your survey, was along the lines of education, professional development. What do you think about agencies offering a mentorship for new nurses?
Well, one of the things that, one of the comments that were made within the body of the survey and at the end did have to do with things like having available a RN, quickly available to those people who are LPNs and working in homes and need some sort of quick consultation assistance. And there were also discussions about having sufficient time to learn an individual child's care and being compensated for the shadowing that's involved in that. I'm not sure if that satisfies or is consistent with the notion of mentoring that is embedded in the question. But it does sound like there is something about this need for sort of support in terms of skill sets and actually doing the work that would be of interest.
It seems to really align with the idea that when you're talking about marketing this option more effectively and positively in the development of obtaining new nurses in this field. Diana, if to sum up the survey, what was your one real takeaway? There was a lot here, a lot of information, so much valuable data that came from this. It was wonderful to see the amount of responses and the diversity in what came from this. What for you was the number one thing that came from this survey?
Well, the people who have chosen to do this work really like this work. In spite of some of its challenges, they really value this highly and want to continue to do it. And that the challenges that they face most often have to do with the ability to maintain a predictable income and to get benefits they need to maintain their health care and to maintain their health. So really those are the features that are most challenging here have to do with these basic sort of low elements on the Maslow's hierarchy to be addressed, the sort of survival and income needs, because for the people who are attracted to this work, the nature of the work in and of itself is inherently satisfying, motivating, and meaningful. Now, that's
Thank you, Diana.
Sure.
Thank you. At this time, I do not see any other questions for Diana related to the survey. So I'll give it back to you, Megan.
Thanks so much, Amy. Diana, again, thank you for presenting this information. I think, I can't think of another data set that really pulls the experience and the voice of the home care nurses who are doing the work. So I think there's so much to be taken from this. I imagine maybe there's not a lot of questions because people's heads are spinning. No, there's so much to take. As Amy said, this slideshow will be available on PA Families Need Nurses Now's website later, so you'll have this particular slideshow presentation, and I'll check in with the Imagine Different Coalition about plans to share broader pieces of data going forward. But I know everybody involved is very excited about being able to look to this data and really utilize it going forward in the work of transforming the way we view healthcare workers and the way we attract and retain them. There's so much to use here. Thanks again. So I would love to turn your attention now, next slide. Over the last year, last year we did the parents who were participating in the nursing summit last year all took part in private interviews as well as their testimonials. And with the support from Philly IDS and with the through Vision for Equality, gave us the reins on a project to start creating some videos around this issue. So we're really, really excited and pleased to share with you today the first video that we were able to produce that just illustrates the importance of home care nurses and the impact they make on families' lives.
Having nurses at home that are aware of their role impacts our life tremendously, because without them, Abby wouldn't be able to stay home. And Abby has a very active life, and she's healthy because she gets one-on-one skilled nursing.
And home nursing has afforded us the opportunity for Brandy to get her care in the home. So the continuity of her health care has enabled her to have a better and broader community experience.
You are not allowed to take a trach child home without a backup caregiver, and it's just me.
We can't make it to work. We can't take our other children to school if we don't have the support of home care nurses. My daughter was able to go on prom because the nurse was willing to come in on her own time and go with her. My other children are safe because I can get the rest I need and can be there for them as a mom and can just focus on Miles's kid needs and not always just his medical needs.
So when you have a good nurse, we can trust that person to stay with Riley, and we can go do something, maybe even have like a date, something that we don't do very often.
So they impact us 1,000%.
Nurses are important to staff a job, but if we started, I wouldn't be able to do all that if I did not have a nurse.
When I have dependable home care nurses, I'm able to just be mom.
So apologies, I'll be a little emotional for the next few minutes, but I think that video sums up pretty well. I hope it does for everyone involved, just how necessary and valuable a role home care nurses play. And as you saw at the end this year, we lost one of our most powerful advocates, Sheila McLeod, who endlessly fought for the rights of her own children and children across the state who have medical complexities and special needs. And we're so grateful for everything we all learned from her and that we all gained from her. So I just wanted to take a quick moment to thank Sheila. And we're just so pleased that we have the video footage to make her a part of this ongoing effort. So with that, I'd like to introduce our panel of nurses and parents to further this discussion around this partnership that is so important and so imperative to creating quality care in the home. So I'm going to start moving some panelists over so you can meet our folks for today. We have several nurses and several, hopefully their videos will begin popping up. Let's make sure that we can hear Frank. Are you there? How about Meg Mom? Or thank you everyone for your patience of the technical fun that goes on with a COVID presentations in COVID times. Do we have Natalie Green? If you all could just make sure you're not muted. Catherine Stokes, are you with us?
Yes, I am.
Hi, Catherine.
Hi, how are you, Megan?
So Catherine was one of our moms who did testimonial last year, and you got to see her in that video. Catherine, I know that was your first time seeing the video. I hope it captured. She's got the tissue.
Cried all the way through it.
Oh. So let's just check in. Catherine, we have you. We have Lisa Kinsey. Lisa, can you? Hi, Lisa. And Marisol.
Hi.
Hi, Marisol. And let's see if we've got some of our nurses on the line yet. Here we go. Frank, are you able to hear us and talk to us yet?
Yes, I can.
Oh, hi, Frank.
Hi, how are you?
Good. So it looks like we have Meg Mom, who is she is a BSN. Meg Mom, I will let everybody give their little background. We have Meg Mom, BSN. Frank, I apologize. Frank Chukwu, is that how we say your name?
Frank Chukwu.
Okay, and Frank is an LPN in home care. Marisol Ramos is with Vision for Equality, and she does an amazing job advocating for children like ours, and also it does a lot of work with the Latino population. Marisol is the mom of a medically complex child as well. And we have Lisa Kinsey, another parent of medically complex children, I believe. Catherine Stokes, as I said, is one of our medically complex parents. Dawn Pye, an LPN in home care. And let's see, am I missing anyone, co-hosts?
I think you got everyone, Megan.
Yeah.
If anyone is on the panel and hasn't been identified, just chat and we'll make sure that you're introduced.
So I want to thank all of our panelists for joining us today. As I had said earlier on, one of our big goals and themes is really making sure that we all come together and stay on track in transforming home care. And no two entities in that scenario do that better than the caregivers and the nurses who work in the home and with their loved ones. So I wanted this year, last year we were really fortunate to have some wonderful professionals from nursing agencies, from state organizations, from advocacy groups, do a panel that offered the professional input around this issue. And it was important to us this year to expand that to the families utilizing the care and the professionals giving the care. So we're really excited. I think, hopefully Diana Plouffe's information, the data from the nursing survey, our video, hopefully has set up a wonderful chance for us to discuss how the two groups of caregivers and nurses can be an example to all of the other stakeholders on how to effectively partner in care. Oh, we have Adalia. Great. Adalia is another one of our nurses joining us today.
Hi, everyone.
So I'm going to just go down the line as I say your name. Please just give us a little bit, you know, what your role is, and maybe just a 1-minute background of how you got into home care, or where you are now. Meg Mom, would you like to start off?
Sure. Hi, I'm Megan Malm. An RN. I started off my nursing career in home care, which was a little different from, I think, others starting in home care. And next I went to a long-term facility for pediatrics. I'm currently working in the PICU for a Philadelphia Children's Hospital, St. Chris.
Thanks, Meg. And then Frank, can you give us maybe like a 1-minute bio? Let's jump to Dawn. I'm not sure if Frank's having technical difficulties. Dawn, can you give us an intro to yourself?
Hi, however, can you hear me? Okay, I can't, okay. I've been in home care probably, well, since I was 17 years old. I started out as an aide with various other jobs. And then I went into nursing school and I worked facilities and still kept my foot in the door per se in home care. And it's just right now, that's what I do. This is my career. This is what I love to do. And this is where I will stay. I've worked with pediatrics as well as adults and senior citizens.
Great. Thank you so much, Dawn. Frank, I see you're here with us. Feel free to unmute and give us maybe a 1-minute intro to you and your career.
Can you see me now?
We see you. Frank, you're an LPN, and you, I know you have a background in education when you lived in Nigeria, and when you had shared with us that when you had to care for your father, it gave you the nursing bug. Do you want to let us know about that?
Yes, I was a teacher in Nigeria before I came to US. You know, actually when I came to US, I decided to pursue a career in nursing, because of the experience I had taking care of my dad, who was sick before I came here. Actually, he was sick for like 5 years. He had he fell down from a bicycle and had a broken leg, so he wasn't walking. Went to hospital. I was taking care of him both at the hospital and when he was discharged until, he passed away. It really gave me a good experience, and exposed me to taking care of someone who is sick. And when I came here, I wanted to train myself more, have more experience, and be able to, continue that gesture of taking care of people who are sick. And that is really what made me to get into nursing, as soon as I came to US.
That's wonderful. Thank you. And we have Adalia Melendez.
Hello, everyone. My name is Idalia. I've been an LPN for 17 years. I started off in long-term care for adults and then transitioned over. I had the opportunity to transition to long-term care pediatrics for medically complex children that were on trachs and vents. And I've been a trach and vent nurse now for 16 years, I believe. I also worked with behavioral health pediatrics as well. And I am currently a field nurse, field home care nurse, but I also work, I do both. I do the field and I work internally for a home care agency, which I'm currently full-time internally. And all my experience has been with pediatrics and medically complex children, trach vents, you name it, I've had.
Awesome. So we have a really unique panelist, Natalie Green, kind of plays all the roles. Natalie, can you give us like sort of a one minute breakdown of your experience, if that's possible?
Hi, everyone. I'm Natalie. I've been working in nursing for over 30 years, pretty much every gamut of nursing there was, but pediatric. I'm currently a nursing supervisor for a long-term care facility. I also work for a agency technology assisted children's home program that works with medically complex children and families around 31 counties in Pennsylvania. And I'm also a mom of a beautiful 7-year-old little boy who has complex special needs. So I kind of work all the hats of it all.
Thank you. And we also have Lisa Kinsey. Can you give us a quick, I know you have a huge plate. Can you tell us about yourself?
Sure. My name's Lisa, and I have 3 kiddos. My youngest is my medically complex daughter. She's going to be 7 on Sunday. She's had home care since she was 9 months old. And I also have 2 other children that have extra needs. My son has severe ADHD as well as oppositional defiant disorder. And my middle child has a migraine disorder as well as depression and anxiety. So I had to leave my profession as a teacher to stay home with my kids. And I spend most of my time in therapies and doctor's offices, and now learning how to manage a household with 3 children that have extra needs.
Thanks, Lisa. Marisol Ramos, if you could give us maybe a minute about what brought you here. I think you're still muted.
Hi, I'm Marisol Ramos. I had 2 young adults. My daughter is Naomi Ramos. She's 24 years old, and she's complex. She had a tracheostomy, G2. She had behavior issues. And also I have my son, Justin, who is 18, and he had autism.
Thanks, Marisol. And Catherine Stokes.
Hi, everyone. I'm Catherine, and my daughter, she was a 1-pound preemie, she was born in 25 weeks. She's now 23 years old. I'm an advocate, and she's been having home care nursing since she was probably 11. So I'm really well versed and real seasoned with this. But this was very nice to be able to sit amongst everyone and listen to the backgrounds and the data, which just kind of really confirms everything that even the conversations Megan and I have had, and even at the Nursing Summit last year. But I come and I'm not only advocating for my child, I'm advocating for other children, and I'm also advocating, as I found out for the last year, advocating for the nurses, because the field staff is underappreciated. They're not given the kudos that they should be given. My team is Team Mariah, my superheroes, because that's what they are. They don't get to hit a button to get somebody to run down the hall to help them. They're on their own. And they do a very good job of what they do. They're the extension of my family. Our family can't work without them.
Catherine, you just sort of segued us to a really good point. So just to sort of set up this conversation, medically complex individuals who are authorized for shift nursing services, which means it's not a visiting nurse, it's a person, it's a medical professional who comes into your home for hours at a time to handle some of the complex medical needs of your loved one who has a disability or a medical complexity or both. That's a unique situation. I don't know that there's any other job, quite like being a home care nurse. Unlike facility nurses, unlike hospital nurses who show up to the same work environment every day, home care nurses are showing up to a different household every day. And not only do they have to mitigate the different medical needs, behavioral needs, developmental needs of the person that they're there to care for, but they have to navigate that family dynamic, that household dynamic in different settings each day for long chunks of time. There are certainly, every employer and employee relationship has to have a level of boundaries. And we certainly know that there are nurses who aren't as good with boundaries and families who aren't as good with boundaries. But maybe you can kick us off, because, you know, one of the things that I think, again, is not just unique, but is really difficult when it comes to home care nursing is that balance. That balance of the professional role that that person plays in the home, but that really personal role that they play as well. And you do a lot to maintain a really strong team for Mariah, and to, you know, even if society or the agency or whomever is not necessarily making the nurses feel appreciated, I know you do some things. So can you talk about, you know, when you and the nurses have a good relationship and a good care relationship, how does that improve care for you and perhaps for the other children and adults that your nurses work with?
I believe that when you create a nurturing and caring environment, everyone flourishes. My nurses are comfortable coming to work. I don't create an atmosphere that you're not comfortable in. That is my job to do, because this individual is coming in to take care of my loved one. So that burden is on me to create a clean and safe environment and things like that, to make sure that the supplies are here. I don't want you to have to root around my home to find linens. Everything that Mariah needs is in arm's reach of the nurse, of the care team. When they first do it, I require a meet and greet. There's no nurse that has ever come and worked with Mariah that I did not meet beforehand. And I cannot stress that enough to families. You can't possibly do that. You have to use your gut. There were times where a nurse came and the hairs on the back of my neck stood up. Mariah went stiff as a board. That was my indication that this just wasn't a good fit for us. I'm not saying that you're not a good fit for someone else, but for us, it just wasn't going to work. And I have to be very much aware of that, because you're interacting with her. You're touching her. You have to be in close quarters in her personal space. So I also have to make sure not that I'm comfortable, but that she's comfortable. My daughter is nonverbal. She's legally blind, but she can communicate. If it's something that she's not liking or feeling, she will definitely let you know. And because I'm so aware of that, I can pick it up immediately. The conversation that I have with nurses when they come, I do ask them, why did you become a nurse? And then I also back it up and saying, why did you choose home care? Because it's either a job or career. And there's a distinct difference with those two things. And if it's a job, I'm going to expect you to come in, do your 8 and skate, your 10 and skate, and you're gonna go. But if it's a career, it's a different mindset that they have. My nurses have been with me 12 years, 8 years, 6 years, and as small as 2 years. And they respect me and I respect them. We have boundaries. I don't ask them to feed the dog or mop the floor. If it's in Mariah's room, have at it. That's your responsibility. But you don't have to go food shopping and stir my pots and stuff. And that's part of when I go out and meet with families who continue to have a high turnover rate. Those are part of the issues. They're not here to do that. They're here to provide the care, the medical care for this particular individual, not to watch your other children while you run down the street. They cannot do that. And once I can get the parents to listen Listening is fundamental. Ignorance is costly. I will tell them that in workshops. Get them to understand, listen, and comprehend that. It now starts to shift. And people really start finding, as I say, their lane, and they stay in it.
Yeah.
It's important to define the roles early on. So therefore, there's no misunderstandings and no miscommunications and actual hurt feelings later on. Because sometimes I think when the relationship starts to go awry, that's because those lines were not clearly defined in the beginning.
Yeah.
And then somebody's afraid to say, oh, I didn't like that. And, oh, somebody's going to get mad at me. And no, I'm right now. And I was telling you, Megan, I'm in the middle of a transition.
Yeah.
Of leaving one agency and going to the other. And probably we're coming up almost like 10 months because COVID kind of really knocked us off our block for a minute because I wouldn't let anybody in my house. And I told them, I said, this is what my plans are. This is why I'm doing this. I would love for you to come, but understand we're still going. So I gave them the opportunity. I gave more than ample time because this was a decision that I really had to make for in the best interest of my daughter. It's not about me. It's my daughter.
Yeah. I wonder if any of the other families can sort of speak to that you know, that unique situation of having a home care professional in your home that becomes such a personal thing. Natalie, I know you have some really personal experiences that have happened, and you know, ahead of time let me know that you'd be okay sharing. There's a lot of partnership that happens in the home between the nurses and the parents or the caregivers, and there's a whole home full of real life happening. And I think it's really important for everyone here to understand the incredibly complex role that home care nurses have to play.
Do you want me to speak?
Yeah, Natalie, if you want to, I'm sorry, I should have.
Yeah, oh no, absolutely. For me, we just transitioned and brought a second nursing agency in my home. For 6 years, I prided on only having one agency. And it's pretty much unheard of now, having a child and having one agency working in your home.
Yeah.
When I brought this other agency in, I gave them the level of expectations that I wanted for my son. What I expected out of a nurse, what I expected from the agency. We did definitely do a meet and greet. I believe the same way you do, Catherine. You're not coming in my house and working with my child unless myself and my child meet you. And I can see, you can tell a lot when they walk in your house, how they interact with your son, like with my son, like if they're looking at my son, trying to talk to my son. So certain things, and he will let his needs be known if he doesn't feel comfortable. So the level of expectation on my part, the nurse's parts and the agency's parts need to be clear from the get-go. Once you meet and greet and you find you think might be that right fit for your home, of course, getting them transitioned to meeting your child, working with your child is huge. I prided myself, like I said, on having only one agency. My nurses were here for 6 years. I had certain nurses, but the comfortability level of those nurses after a period of time started to lax. Then certain things were being, my son's safety was being jeopardized. So it comes to the point, you are the parent, the caregiver, and the employer, so those lines can't be blurred. We were taken advantage of at one point with 2 nurses, thinking that, they thought their comfortability level was okay to do certain things when it was not safe for my son. And as a parent, you get scared because you're like, they'll pull the nurse, you're not gonna have anybody else to cover. I work 2 jobs, I'm a single mom, like, what am I gonna do? So, it's hard to make those crucial decisions, but if you start from the beginning and have that expectation of what you want and what you expect, and we do value, we have one nurse that has come back, thank goodness, last year, who's known Xander since, he was very little, who is exceptional with our son. And we make sure that she feels appreciated, and our night shift nurse. We might do little things to make them, we're always telling them, because they feel very undervalued and underappreciated by their agencies. And it shouldn't be that way. So there's a lot that goes into it. And once you have that well-rounded nucleus for your child, because I call the child the nucleus, and it's everybody that works with that child to make them thrive and grow. It's a great life for your child. Getting there is very tedious and very hard. And as a parent, we have to be persevere and not give up. And it's very easy for parents too. With the program that I work with, we work with parents and trying to give them, parent empowerment and make sure they have a voice and they know how to voice for their children. So it's hard. It's hard. It's a daily process. It's also a rewarding process. My son is growing and thriving and doing exceptionally. He is trach vent. He has trisomy 18. He's had a heart condition, which, we've had fixed, but, there was something else that happened. So there's a lot that goes into details with him. But he's doing phenomenally well now. And that is I can't thank the nurses that I work with enough, the doctors that work around my son, the therapists and the itinerant teachers. Right now with COVID, my nurse is a jack of all trades. She's the PT, she's OT, she's vision, she's speech, she's everybody to my son. So having that perfect fit, and we didn't always have a perfect fit. We've interviewed several people that we knew weren't going to be a right fit. So, it's hard, but it's in the long run, it's rewarding because this is my life.
Yeah. You bring up when you said the nurses now, PT, OT, speech, they do a lot of that, even outside of COVID times. Some of the nurses go to school with the kids. They're there when the parents are at work and they have to help implement strategies for children who maybe aren't simply medically complex, which is so silly to say, simply medically complex. So Lisa, I know you have a really unique household with a lot of varying needs. And I believe only one of your children is authorized for shift nursing. Is that correct?
Yes.
But they're certainly in an environment that has a whole lot of different needs. And can you talk a little bit about how you and the nurses have perhaps, and I know you struggle like the rest of us to even have continuity of care with nurses, and there's, fluctuations in staffing. But, maybe talk about the nurses who have done that well with you.
So I'll start with, we just moved here to this area about 3 years ago in May. And of course, when you move to a new area, you have to start all over again. Before we moved here, we'd had the same nurses from the time Sarah was 9 months old until after her, almost to her 4th birthday. So it's a long time to keep people in your home. Like Catherine said, they are an extension of your family at that point. And so when we moved here, that was my number one goal in finding care for my child, was that people in my home would understand that they're a part of our family now. I have to be able to trust them completely with my child's life so that I can take care of my other 2 kids. And it's not always easy. I might have someone come into my home that is a wonderful nurse, but the personality is not there, or they don't have experience with the exact needs of my child. Actually, one of the nurses that just started with us about a year ago, she had never seen a G-tube change before on a person because she came from a facility. And so I walked her through her first G-tube change in a home. And for me as a parent, that's amazing that she trusted me enough to teach her that. But at the same time, that calls into question the training that these nurses are receiving before they come into homes. When Sarah came out of the hospital last summer, she came home with a PICC line. She's had 2 ports, she's had 2 Broviacs, and then she's had 2 PICC lines. So she's got a lot of, we've got a lot of experience with central line access in our home. And for us, it's second nature at this point. But when we're interviewing agencies, sometimes they send in people who have never seen these things before, and it's scary for them. So looking at a nurse who has never touched a line before or seen a line before on a person, not just a doll, but a person. These are things that you take into consideration when you have people coming into your home, and being comfortable enough to say, okay, this is not going to work, or okay, let's see where we can go together as a team. Because once I teach a nurse how my home runs, how the expectations of the shift care and the insanity that is my house, it is never quiet in my house. My son is 13, but there are days when I can't leave him, and especially with this COVID business going around, with distance learning. I had to sit next to him the entire time for school because he could not do the work himself. My other daughter was in the hospital this year with these migraines. She was very sick, and while they were figuring out what was going on, and then the therapies and things that she now has to do, I have to be able to give all three of my children 100% all the time. And if my nurses don't have a good relationship with my daughter or with our family dynamic, then that can't happen. So that's just another way of having to think about what these people are when they're coming into your home. They are a vital service in your house. Sarah's doing ESY, that's extended school year, if you don't know what that is. And I can't be in the room with her for that because Sarah has a lot of trauma in her world. She needs mommy. Mommy is comfort and care and love, and school's hard. Part of her genetic disorder, she has a rare neurogenetic disorder that makes her very tired. And academically, her brain gets so tired so quickly. Her nurses have to be able to stand in and comfort her so that I can then comfort my other kids and take care of my other household duties, because my husband's job does not allow him to be a caretaker during the day. He works a minimum of 60 hours a week as an attorney, and if trial time is coming up, we may not see him for days or weeks on end because his job requires it. And that means I have to pick up everything else.
Thanks, Lisa. I want to make sure that I give everyone a chance to talk, but I wonder if one of the nurses could speak to that. You know, Lisa brought up a really interesting topic that those of us who are medically trained to care for our child and who utilize nursing are well aware of, that not every nurse who comes in your door, in fact, quite a lot of them that come through your door, while they may have experience, they don't have experience with your child's unique needs or your individual's unique needs, your loved one. But they may also simply not have ever have practiced the skills that they're there to do on a real person. I've lost count of the nurses I've trained to do trach changes. I'm not a respiratory therapist or a doctor or a nurse, but I am the key trainer in my household. My husband is a key trainer in our household for trach changes. So, you know, nurses, maybe Dawn could speak to this, or actually Adalia, I know you've done home care and you've sort of done the supervision side for nurses, correct? So in those times when, you know, parents have to step in as the trainers, nurses come in with their knowledge, and I'm sure they feel as prepared as they do. Sometimes that can be a weird dynamic when they're there to provide the support, but the parent who's not technically a supervisor, or the wife or loved one or sister who's not technically the supervisor, has to supervise a nurse. How have you helped nurses navigate that, or you yourself navigated that?
I've always like when I go, like I said yesterday, I will never allow a nurse to go into a case that they're not skilled to work, because it falls back on the nurse and the agency. I always tell the nurse, listen to the parent or their primary caregiver. They were trained to do this. You're trained to do certain things a certain way, but this is their child. And if, you know, some parents don't want the neck roll behind when they do the trach change, because they feel it's uncomfortable. So I always say, listen to the parent, and you use your nursing judgment, and then come in between, you know, come to a fine agreement on how to do certain skills. But the parent is trained very well to do the job, to fill in when the nurse is not there. And a lot of our nurses, like Miss Natalie said, you know, they're not trained to do certain things, G-tube changes. You know, you can be a nurse for years and you've never done a G-tube change. A lot in part has to do with in home care, the parents feel more comfortable them doing all the trach care changes, all the G-tube changes themselves, which is fine, but it takes away from the skill from the nurse herself. And we do have a lot of cases that, you know, the parents do the skill themselves, but I always tell them, depending on the case, utilize your nursing skills and come to an agreement and see how it plays.
Thank you. Thanks. And I wonder if any of the nurses on the panel here, have you been in a home where perhaps, you know, we have a we have a pretty impressive group of parents here who are take charge parents who have just jumped in as all the roles. That's not necessarily the case or capability level of all parents who have a medically, or all caregivers who have a medically complex individual. So if we're talking about an elderly patient, their loved one may not have the physical capability, or if we have a parent who is disabled themselves or a loved one who's disabled themselves. Has anybody had an experience where they've been put on a case where the perhaps the caregivers in the home aren't as well trained or aren't as able to provide that guidance, and how do you flip that and be the person that then trains them or supports them more effectively? I wonder if maybe Dawn, given her years of experience and the multiple types of environments she's worked in, might have something to say there.
Sorry. Can you hear me? Okay. I actually have had quite a few of these type of cases where I've worked with families that their children, for instance, they were disabled and their children were disabled. And the functioning of the household, not that I crossed a boundary or anything, because I always make sure my boundary is set before the meet and greet. This is what it is. But they didn't quite understand some things to look out for. And the child was burnt in scalding water. She's okay today. This was 10 years ago. The child no longer was living with the parents at this time. They just didn't have the support system in there. So it falls a lot on not just going to the agency for support as the nurse, but I had to reach out to different agencies as the nurse to try to get support for this family. And a lot of times I wasn't getting that. So it became a medical emergency for this child. It happened as I was coming on shift, and it didn't have to be that way, because I seen things in the home that the parents just didn't understand. They didn't have the support. And it wasn't a high acuity case, but nonetheless, it was still a child that received skilled nursing care in the home. And from the school, everything. I went to school with the child. I tried to get the school really involved, until it became a life or death situation, honestly. Then they jumped in. So that I've had a couple of these. I've had them working with the elderly a lot. So just being not only the person that's going into the home to provide the care, trying to get the support to come in with us that they may not have. And I wear home care nurses, I know for myself, I wear many hats. So it's just trying to get the outside care that they would need in the home. And I've seen plenty of cases like this, that it's their child, it's their loved one. They know when they're leaving the hospital as far as what what has happened. It could have been an accident. The child wasn't born this way. The person wasn't born this way. They're overwhelmed. They have needs themselves. And by the time we get into the home, well, in my case, hands are thrown up in the air a lot, like, please, they're drowning. They're drowning. I've seen this. So, again, wearing many hats, trying to get to and providing as much education as I can to what I have. A lot of mine is life experience along with the nursing experience. So trying to just stay together as a team, work as a team. I'm trained in one certain way as far as nursing school and my experience as a nurse, but I'm also a human being and I've had life experiences myself. So again, it's just, I've had the gamut of the parents teaching me and training me to I've had to go in and train and get services and cry out for help and scream for help to try to get services for these families that desperately need it.
You, Dawn, you guys you're amazing. You're just sort of bringing us to the points that we want to make without even knowing that they're the points we want to make. One of the things that we've heard from nurses and across the state that we've talked to is that they feel, even though they feel skilled, they feel underprepared for the home care environment. And I believe I sort of see something popping up in the chat about this. There are nurses that feel once they get in the home, they were not well trained enough for doing those types of skills autonomously, alone, without a backup of a hospital or a facility, and that they wished that there had been more training around not necessarily just the medical skills, but when, there's a lot of times the term problem family is thrown around or problem case is thrown around. And we like to try to get everybody to sort of shift their focus and recognize that oftentimes these are families with more problems. So what nurses and parents, maybe somebody could wave their hand to see if they want to talk. What do you think we could provide? What do you think we could provide to nurses coming into the field to make them feel more prepared? What, Dawn is advocating for services, social services for families beyond what is clearly medically needed. How could we help? How could we as groups form systems that help prepare nurses for all the very, very many different experiences and situations they're going to run into in home care?
I honestly think that one of the biggest things that needs to happen is that when you have these brand new nurses, I call them our baby nurses, coming in from nursing school, they are so excited about their job. However, they're walking into not a facility where they were taught. They're walking into a home. It is a whole new gamut. We are not sterile environments. We are not, we don't have managers breathing down their necks all the time. Sure, they have their case managers just like we do, but it's a whole new environment. Those poor nurses need to be given an opportunity to learn in the home before they are set free in the home. Again, parents, we don't necessarily mind teaching the nurses how things work in a home, but that shouldn't be our job. We should get to be the parents. We have to be nurses and therapists and teachers all the time. Sometimes we just want to be the parents, and that should be okay. When the polls were given to the nurses around the state, one of the things that they mentioned was that they don't get paid for these shadowing times. They absolutely should be getting paid for these times. I wouldn't want to come into a situation where I'm learning on the job experience and not getting paid for it. That's not fair. That's not appropriate. No one else in any other circumstance would stand for that, and it shouldn't be that way for home care nurses either.
Hello, Megan, can I speak?
I'd like to let you jump in. I hope that you can give us some perspective around, perhaps, in addition to what you're about to say, the added barriers that might be in place for families who are Latino, who come from a different culture, or who speak a different language as their first language, because we're all experienced now in this, but not everybody has the same access to resources or has the same communication capabilities, or is simply treated or viewed the same. So Marisol, jump in, and then if you could sort of, whatever you're saying, sort of twist it around to that as well, I think it would be really helpful.
Yeah, it's a lot of things in my mind, but first of all, I think the nurses, like the school nursing, is good if they can giving trainings in families' homes, like if the school can contact the home health agencies and try to go with to send nurses to do the training in families' home, because that way they go to see how it is. Talking about the Latino families, sometimes it's a lot of misunderstanding. Sometimes they send people who really don't understand the language, and that can be a barrier for miscommunications. When you send nurses, like I got to talk about my personal experience 24 years ago when my daughter came home after 1 year being in the hospital. It's really hard for me because at first I don't communicate well, but they send me several nurses who are not really well trained, because you have to understand, in the hospital, the nurses who were in the hospital had help with the ventilators and all that stuff. When they change the tray, they use 2 people to change the tray. But when you're at home, sometimes it's the parents don't understand how to do that, and the nurse is not well trained, can happen an accident. And I see that because I remember when my daughter came home, I resist some nurses who really don't have the training to change the trays, because they were before in the hospital, and in the hospital, 2 nurses are the ones do the tray change. Also with the ventilator, when you go to work in a home, when a patient has a ventilator, not everybody know how to work with a ventilator. So parents have to, when I bring my daughter home, I had to go to a really long training for taking home, because the only option I had, or take home or send her to an institution, and I don't want to do that for my daughter. I wanted my daughter had the same opportunity like all the kids had. So that is why I decided to take her home, and I go through all that training. So it's really important, I think, like nurses go to a trainings in the different settings, not only in the hospital. I believe it's really important go to family houses for know the dynamic, for understand and have the empathy. I always feel like a parent, I have to be respectful and value the work for the nurses, and I value that because I recognize through all these years, at first, and an independent person who I don't want help. I want to do everything by myself, but I had to hit the wall and understand I cannot do it by myself. I need help. And the nurses are really valuable for that reason. And I appreciate the work, because it's not easy to go to a home and people have different rules in the homes. So I always try to understand the person who is really important is my daughter and my son who need services. So I work with the nurses like a team. So family had to make sure they are a team, like each one had the voice. Every person, not only the families, the nurses also had a voice. And with the Latino families, sometimes Latino families feel they don't have the voice because they don't understand well the language, and sometimes they don't have help with interpreters to can help them, interpreters. So it's really hard for some families. I have families calling me crying because they feel like they don't understand them and they want the best for their kids.
Just like any of us, every family and caregiver of a loved one with a medical complexity and disability, we want the best. And some of us just have the capacity to access that a little bit better than others, and not by fault of the families, but by fault of the systems that serve them. I think what I'm hearing from so far and from the chat, from the group, there's a real need, and I hope that the nurse training programs that joined us are game to jump in here. I think we should get really creative. What I'm hearing is about making opportunities for nurses still in training in their education to have access to families like ours, to have access to home care agencies, and perhaps think about building partnerships between nurse training programs and agencies on a deeper level. And we as families who have the ability have to be willing to open up our homes a little bit more. It's disruptive, but it's so necessary for all the patients across the state. That's certainly harder for some households than others. You know, I imagine a Lisa household, that would be so incredibly disruptive to all of the dynamics that are happening there. But perhaps for a family like Marisol, where the children are a little older and she might be able to have folks in, that could be a really powerful solution. I do want to make sure that we're being really clear about what agencies and what sort of the systems overall. Families and nurses are working all the time to try to build these partnerships and to maintain them, but we can't do it alone. So obviously there's the agency component, the organizations outside component, MCOs, the state, everybody who impacts us. And I think what's really important to know here and to really speak to, and I want to make sure, again, I'm willing to go a little bit over into our break. I hope everybody else is. Catherine, if you, this is such a big issue, but if maybe in like a minute or two, you might be able to speak to some of the issues around cultural competency and perhaps even just, representation on the agency level.
I've created a workshop. It's called Just a Conversation from a Parent's Perspective. And I have offered to go in to agencies, insurance companies. I've spoken at schools, different levels, because there's different levels to home care. And one of those things is understanding accountability. I should not have to ask an agency representative, has the nurse seen the 485 before you send them out to my house? But I do. And if they have not, I stop them in their tracks because I don't think that it's fair. That's like me selling you a car sight unseen and you never test drove it or anything like that. My child cannot, this is not a science project. And I've had nurses who were brand new out of school and they said, I've never done this before. And I said, are you willing to learn? Are you open to learn? If you're open to learn, I'm willing to teach you. Because there has been times where years down the line, I've run across the same nurse in a hospital and they're doing phenomenal. I'm like the biggest cheerleader of nurses. They may come in as a CNA and I'm like, okay, well, what you gonna do? If this is what you want to do, I'm gonna support you. But if you wanna go to nursing school, I'm gonna support you with that too. Because we still need great nurses as you move over, because now we need more CNAs. But I hold the agencies accountable for a lot of stuff. For all of the years I've had nursing care, I should get a W-2. And I'm just putting it out there like that. I should really get a W-2 because I tell them how my household runs, who's off, who's on, who's going on vacation, who's covering, because I have no confidence, zero. Let's go to -50, that they're going to do it and do it in a timely fashion. Timing is everything. If a nurse gives you 4 to 5 weeks notice that she's going to be going on vacation at X amount of time, and then you want to wait till the week of for night shift coverage. Now let's go there. That's where it gets interesting at. Night shift coverage, and now you're saying that you don't have anybody. Well, that's interesting. So I hold the agencies accountable. And I mean, to the point where I call corporate offices and things of that nature to let them know that they're dropping the ball. But again, I go back to the state representatives and things of that nature. Who's watching the hen house? Nobody's really watching. Everybody's kind of doing what they want to do with no repercussions of what they're doing. But I try to be a part of the solution and try to help them.
Particular, Catherine, maybe you can tell me about, I know you go to other families, sometimes you're called in to help other families who are not necessarily navigating the system as well as you or I are. How do you help them become, how do you foresee the dynamic there, not just in the way the family is not providing a safe workspace, but perhaps the flip side of that and how differently those families may be treated from our families?
Oh, it's a huge difference. It's like that squeaky wheel gets the, I don't even know the term, is that they know who they can send to my home and who they can't send to my home. So that distinction right there tells me that the playing field is not even. Are you spending enough time in your interviewing process for your employees to know what everybody has strengths and weaknesses? I have them, you have them, everyone has them. But the being able to marry a family with a nurse, it is a difficult process. But however, I am here to say that I think I'm not gonna say hit the jackpot, but I'm starting to get into a comfy space with the new agency that has stepped into my life. Because they're responsible. Even when my nurses went for orientation, they said, wow, this is really different. I said, and you know what I told them? Because you've been doing it wrong for so long, now you're being corrected how to do it the right way. And we are all in a space of learning to do things in a better way. But I just try to help my families. Families call me all the time. Well, I don't know what to do about this. And I'll help them word emails. I'm an email person. Verbal is fine. Email hard copies are better. Trust me, they are. But just teaching families how to navigate, because there's families out here like you and I, but then there's also a lot of families out here who can get a denial letter and don't realize that you can file an appeal. And that hurts me, because now they're going without services that they absolutely positively need, and they have no idea how to navigate this system. This is not for the weak and weary, believe me. It's not. I spent many days crying and upset and sometimes having to walk away in order to come back another day stronger with a clearer mind. So I just try to help the families.
Yeah. So I think one of the things knowing is that not only are not all nurses and families and patients not the right dynamic. Sometimes the agency and the nurse are not the right dynamic. Sometimes the agency and the family are not the right dynamic. And I think
I've done that. I've referred them to other agencies because of that.
Yeah, on all the levels, I think it's important, as we're talking about how do we all better partner in care, perhaps, making sure that the nurses and the agencies are all aware that this isn't just a transaction. For us and for the nurses in particular, it's not a transaction. And I think a lot of the people that go to work for agencies also, their heart is in it, but there's a company involved. So maybe fostering that idea that sometimes people are going to have to move and we have to be supportive of that. That's going to happen. Things change, couples get divorced. Sometimes families and agencies are going to have to get divorced. Sometimes nurses and agencies are going to have to get divorced. But the most important factor is the continuity of care for the patient. So I'd love to, two things. I want to make sure we get to Frank and to Meg. I think, Meg, not to say anything, Meg could be sort of Meg and Mom is our cautionary tale, right? She is a nurse. She's at BSN, really strong, in a really huge heart, strong instincts, learns fast. I'll admit she was one of my nurses. But we home care lost her to the facility world, and then when she moved up into the ICU. Meg, if you could just talk a little bit about what could home care have offered you? to keep a strong nurse like you in the field and make this your career?
I think part of it is definitely just the training. I learned how to change a G-tube through you. Personally, like and we had a class on it, and it's just so different on a body, like a real human baby versus that little plastic thing that they say, oh, you just put it in the hole and it's fine. And even trig changing, I learned that on another home care case I did. That mom had to like step me through it, and like in the middle of the night it came out once, and I was like, oh my gosh, what do I do? Opposed to in the facility, I was exposed to it more, and now I can change a trach with my eyes closed. But home care didn't offer me that. They just gave me 1.5 hour class and said, this is how you do it. Okay.
Do you, I know you worked in a few different homes, and there were some situations you even had where there were sort of some safety issues around your property. There were safety issues around what might have been going on in the home. Do you think that your agency, is there some way your agency could have better supported you, or the systems could have better supported you in terms of, or better supported that family, maybe identified or given you the support to figure out what was actually going on there that could have made the situation better for not just you, but for the family and for the kid?
That was pretty confusing, the whole situation. So my car tire was slashed about 3 or 4 times when I was working with one family. And the agency I worked for did end up offering to Uber me back and forth, but there wasn't any like investigation as to who was doing it, or like, was it me the target, was the family the target? They just kind of were like, here's an Uber. And I think maybe if they would have tried to see like, oh, like, is there an ex-boyfriend, or is it like that the parents weren't together? Is it the dad, or what was it? It was just kind of dismissed as like, oh, who knows? Here's an Uber. So I think I would have felt a little like safer if they would have tried to figure out more what was going on.
And that certainly, I imagine, would be a difficult process for an agency to even engage in. So, you know, there's those of us who are really active in advocacy and whatnot, like the Catherines and the Megans and the Victorias and the Glorias, we really try hard to connect with families to maybe on our end figure out what's happening. Frank, I want to ask you, as a person who also went straight to home care, you've been there for a while now. We're getting short on time here, and I want to make sure that we recognize that the home care workforce is as important as it is, and we have some folks that are starting out there. What do you think, given your experience so far, what are the things about home care that could be better for you as an employee and as a professional to help you feel like this is a long-term world for you?
Thank you for giving me this opportunity. Actually, you know, I have felt good, you know, working in home care since graduating as a nurse, and I've felt all good about it. I give it all my time. I give it everything I have. I always go to homes, you know, to work, you know, knowing that I'm actually going to take care of somebody. And the first thing I do when I get to a home is to make sure I understand the person I'm taking care of, you know, the personality and everything about that person. And by so doing, you know, I'll get a handle on what to do and what not to do. Well, some of the homes I have been in, you know, I have felt good. I have been valued, you know, as a worker and as somebody who knows what he is doing. You know, and in some areas, you know, they just look at me as probably, what are you, by the way, doing here? You know, I mean, have you come to work? Or, I mean, they look at me as if the job I'm doing is not valid, you know, so it happens anyway. But when that happens, you know, I still have to and put it aside and make sure I do my job, because that is what I'm there for, So what I would like to say is, because I have also listened to some nurses, that, when they go to home care, do their job, their job is not valid, they are kind of looked at as, I mean, this is not even a job you are doing, kind of, I mean, what are you doing in this field, kind of. So it's just for, the agencies, to, well, communicate it to the homes, I mean, this is a job like every other job, even if, I'm in the home care, I'm also a qualified nurse as somebody in the facility or in the hospital or like any other kind of job, so
Right, right.
yeah.
Yeah. And I think that, goes back to sort of what we were talking about earlier, is that there's this stigma. And I think, recognizing that the nurses in home care are just as qualified, and they're trained in the same way and with the same licenses as the folks who go to facilities and the folks who go to hospitals. They just choose this other path. And that path is just as valuable, if not sometimes more valuable. As the home care world and the capabilities are expanding, we need to value the nurses that are doing the work with families like ours. And I think that the families here and the nurses here all seem to have a strength in the sense of partnership. So I hope that, the folks that are out there watching and listening can take some of what we've talked about and implement that in whatever world of this industry you're in, and just maybe be inspired by the need to really facilitate those partnerships and to make sure that the patient is always the center of the nucleus, as one parent put it. So that continuity of care for that patient, and as low disruption as possible of their care and their well-being is paramount to everything else. I didn't see very many comments coming up or questions coming up in the chat. I don't know if anybody has. If Amy, you want to just check and see if anyone wanted to ask a question, and then we'll take a 15-minute break.
There are no additional questions for this panel. They've done a phenomenal job of addressing their own lived experience, solutions to the crisis, and information as we move forward for solutions for all.
Thank you so much, panel. Thank you for everything you do for your kids, for the kids you work with, for the adults you work with, for the families who need you. And again, I do truly hope that the folks in the summit who don't necessarily have a loved one with a medical complexity understand this unique world that we all live in and how important it is to support it, to make sure that loved ones with medical complexities and disabilities can live at home safely and their families can flourish in the same way that everybody else has the opportunity to. So let's take a break until 1 o'clock. We'll come back together for a session around raising voices, and advocates and policymakers are going to share strategies for families and providers on how we can all make an impact on multiple levels and how to transform home care. Thanks again, panel, and I hope everybody joins us again at 1 o'clock. We're just going to do a quick pause. We're getting close to 1 o'clock. We'll give another couple minutes for folks to come back. I know that was a shorter break than anticipated, but I'm glad we got to talk about all the things we got to talk about. Just as a reminder to the folks participating, we appreciate how well everybody's been doing. Even on panels, we've had some multiple people as panelists and keeping themselves muted. Remember, we're going to do all questions and answers, the Q&A session sort of after folks wrap up talking about their particular presentations or their area of expertise. But all the while, we welcome you to use the chat box to the chat function to throw up your thoughts, throw up some questions. And as the time permits and as we get to the end of the presentations, we'll share those questions and comments. If you'd like to be unmuted, just please use the icon to raise your hand. If you're phoning in, if you're using the phone to dial in, Zoom claims that you can press *9 to raise your hand. We haven't seen it happen yet, but hopefully it's an actual function. Living this remote world, we're all just still sort of learning how how bringing people together like this works in a virtual way. So additional thank you to everyone for your patience and perseverance as we transitioned this summit from an in-person event to one that is online. Hopefully that actually opened it up to more people who could be part of the day. So with that, I want to bring us back from the break. It looks like we still have a good chunk of people. I'm very happy to see that. I appreciate everybody sticking around. I'm really excited about this next session because I think it really, without even knowing it would, it really ties back to what Nancy Thaler talked about this morning in her keynote of effective advocacy and unifying a voice. And this, I think, in this session, caregivers, agencies, providers alike will hopefully walk away with some information on how to do that effective individually and what options are out there for individual advocacy when you're experiencing an issue around medical complexities or disability or healthcare, but also how to be a change agent and an active member of the changes that are happening on a state level and even perhaps a national level, even with your limitations of perhaps not being able to get out as much as the rest of the world. So I'd like to introduce our Raising Voices Advocates and Policymakers panel. We have Dana Casserly is an attorney, supervising attorney with the Pennsylvania Health Law Project, PHLP. She also sits on the Pennsylvania Families Need Nurses Now Advisory Council, and she is the magician who has been making the slides move this whole time. Thank you, Dana. We have Erin Gabriel, who's the Director of Advocacy with Little Lobbyists. She's also a Pennsylvania resident, and she also heads up the PA chapter of Little Lobbyists. Or at one time did. Maybe there's someone else who took that off your plate. We'll find out. No. And Laura Ness, we're excited to have, she's the Director of Government Affairs with Beata Hearts for Home Care. So panelists, thank you so much for joining us. Next slide, Dana. I'll turn it over to you.
Thanks, Megan. You can hear me okay, right? All right, great. Good afternoon, everyone. My name is Dana Casserly, as Megan just introduced. I'm a supervising attorney with the Pennsylvania Health Law Project, and I'm going to tell you a little bit about our organization. So PHLP is a statewide nonprofit law firm that represents all Pennsylvanians who are having trouble accessing or keeping their Medicaid coverage and services. So that includes anytime somebody needs to get health insurance through Medicaid, and it also includes folks who have the health insurance through Medicaid, but their managed care plan, their insurance company essentially has denied a service that their doctor has prescribed. We sort of take a three-prong approach to our work, and you'll hear me talk about my individual casework in a moment. But at PHLP, our motto is helping people in need get the health care they deserve. And we think that the way that we best go about that is the approach that we have, which is representing individual clients, engaging in systemic advocacy, and getting out into the community and doing community outreach and education. So through our toll-free helpline, we serve thousands of individuals from across Pennsylvania every year. And we listen to those stories that we hear from our clients, and we translate their personal experiences into legal problems to be solved. So legal, the cases that we bring, like we talked about, somebody who might need Medicaid insurance, we might represent them in their hearing to get that insurance. Or my specialty as an individual case handler is working with kids with medical complexities who require shift nursing in their homes. When a managed care plan denies that service, we step in, and I step in, and we help the families fight the insurance company to get the services approved. So taking what we learn from those individual cases, we also engage in our second prong, which is the policy advocacy that we work on. So we advocate for policy changes, mainly at the state level, that help others across the state beyond just our individual clients. And we also seek to build capacity among consumers, healthcare providers, and other advocates as well through community education and trainings. So we offer a broad range of trainings. We get asked to speak at different occasions and different conventions and things like that. And we'll come in and do smaller trainings maybe for providers. So I personally do a lot of trainings for nurses on how to keep good medical necessity documentation, so that when we go in and try to fight that battle through the hearing process for our clients, we have nurses that we're working with that we've kind of built that capacity up for them to understand what it takes to win a case like that. So that's a little bit about what we do. We will, of course, talk more through our Q&A panel, I'm sure, and you'll get to hear a little bit more about my day-to-day and sort of how I help families. But if you'd like to connect with the Health Law Project, you can visit our website, www.phlp.org. We've just revamped our website, and we're really proud of it, and it has a wonderful resource library with a lot of self-help materials. So anything on Medicaid eligibility, how to fight an insurance denial and file an appeal, things like that. And you can also connect with us through Facebook. We are active on social media. And finally, I put our helpline phone number on an earlier, I'm in charge of the slide, so I can do this on my presentation. I put our helpline number here on the slide. I probably should have added it to the last one. But through our helpline is how we reach clients. So today you'll hear me talk about the individual services we provide. If you have someone who needs our services, all of our services are completely free. There's no income limit to qualify, and you can direct your patients, your clients. You can call yourself if you're a family member who needs help, or you're an individual that needs help. You can call our helpline, and we're open on Mondays, Wednesdays, and Fridays from 8 a.m. to 8 p.m. and that's for client intake. All right, so with that, I will turn it back over to Megan, who I think will just briefly hand the baton over.
Yes, thank you so much, Dana. For those who don't know, there's a wonderful organization that started around, I want to say around 3 years ago, and I just happened upon them by way of Facebook and personal issues, called Little Lobbyists. And we're really fortunate to have, again, we have Erin Gabriel, who is not only the Director of Advocacy, but is a PA resident herself who has children with healthcare complexities. So Erin, take it away.
Hi, thanks, Megan. Like they said, my name is Erin Gabriel. I'm the Director of Advocacy for our national organization, Little Lobbyists. I'm also the state chapter leader for Little Lobbyists Pennsylvania. More importantly, I am Colin, Bridget, and Abby's mom. We live in Beaver County in Western Pennsylvania, which is just north of Pittsburgh. We are a family-led organization, and we advocate for the healthcare, education, and community inclusion that our children with complex medical needs and disabilities need to not just survive, but thrive. We are here to talk about family advocacy, and that is basically the center of everything that we do. We advocate alongside our children, as opposed to some people advocate for their children or for themselves, but we are family led. So in 2017, I think you all remember the threats to the Affordable Care Act. There were some moms sitting together after a birthday party with their medically complex kids. And they said to each other, what if we just showed up with our kids? What if we just bring our kids to Capitol Hill and make these senators and congressmen meet them and make them see who they're going to impact directly with these votes? So that's what we did. Our founders, Elena Hung and Michelle Morrison, and several other families started bringing their children to Capitol Hill. And they, with or without an appointment, just started walking into offices and introducing themselves and introducing their children, and their children were meeting with the senators. And over time, these families and our children have become commonplace almost in the Capitol. And many of the senators actually know our kids, and they get to know our kids, and they get to watch our kids grow up. And that's one of the huge successes that we have had, is that there is a personal connection. And that personal connection is actually super important. I know my own congressman has actually said to me, I was wondering how this legislation would affect Abby, my daughter. Like, he actually thinks about my kid when he's making these decisions. Another thing that we do is we realize, obviously, that if you're in California or even Western Pennsylvania, or anywhere that you can't necessarily bring your medically complex child with you to the Hill. Sorry, Abby's singing for you. We collect stories from all over the country, and we actually go to those senators and we say, hey, with our own kids in tow, these are other kids just like ours who actually live in your district, and these are their stories. And that's been actually tremendously successful in terms of getting senators to listen to us, getting legislators to make decisions with our kids in mind. And we would just ask that if you are interested in getting involved, you would join us. We have a story form, littlelobbyist.org/story form. It's pretty easy to find on our website. And fill out a story. It just takes about 15 minutes. And you submit a picture, and we actually print out those stories and we bring them with us when we meet with legislators. And often we have speaking opportunities or opportunities to share your story directly with your legislator in other ways. So we use those stories to find our families and to introduce them directly to our legislators. And it's a really empowering experience for the kids too. I know my daughters love to talk to legislators. Abby, my youngest, is nonverbal, but she has her own way of interacting with legislators, and it's really an empowering thing. I have pictures of her sitting behind her congressman's desk, and we always try to operate with the understanding that our children with disabilities will grow up to be adults with disabilities. And we have had so many adults with disabilities tell us how empowering that image of our kids in a congressman's office or in a senator's office, one-on-one with them, when it wasn't too long ago that kids like ours were institutionalized and kind of shut away. So we try to operate, yes, with the healthcare community, but also alongside the disability community that we hope our children will grow into one day. So as the slide says, if you'd like to join us, you can find us at littlelobbyist.org. We're also on Facebook. We also have a Pennsylvania chapter on Facebook that is a private group. You can find us, you just have to ask to join. And that's Little Lobbyists Pennsylvania. And we're fairly active in there. We've only just rolled that chapter out a year ago. So this COVID thing has slowed us down on the in-person stuff there. But we're pretty busy still. We're doing a lot, and we'd love for you guys to join us. Thanks.
Thanks, Erin. And next we have Laura Ness is here from Hearts for Home Care Advocacy. That's a BAYADA program that supports quality home health care. Laura, take it away. Feel free to give us some information about what your organization does.
Sure, absolutely. Thank you for having me here today. So Hearts for Home Care is really the arm or the grassroots program that is run by Beata Home Healthcare at the moment. And to give you a little bit of background on Beata, in case you're unfamiliar, we're the largest nonprofit home healthcare company in the US, and certainly the largest in Pennsylvania as well. We actually started in Philadelphia about 45 years ago, so a Pennsylvania native company as well. And it's today still our largest state with the most number of clients, offices, and service lines that we provide. And one of the major service lines that we provide, that's about 1/3 of our business, is pediatric home care. So it has always been an issue that's been near and dear to our heart. So with the creation of Hearts for Home Care, we kind of officially codified this program, and the initiative really aims to involve our caregivers and clients, as well as their families, to advocate to state and local legislators about the importance of home health care and provide a lot of the education. We've found over the years that home care is one of those things where you don't know about it until you need it, and oftentimes when you need it, it's kind of too late to start that process, and it's just very overwhelming. So so we try to make sure that legislators have an idea of what it is, so they can educate and help their constituents when they come in the door. But also these legislators, when we're having more and more turnover, we're finding that they have no idea what home care is. And what we've learned just from working in home care is, or we know very, very well, is it's an industry that is incredibly regulated by the state and federal government. So these legislators that have kind of no framework or no base knowledge of what home care is are making decisions that affect our employees and affect our families and our clients every day. And we want them to make the most educated decisions that they possibly can, and of course, make decisions that will support home health care and policies that create policies that are supportive of home care as well. So we know that, also what we're finding with legislators is being a director of government affairs is all fine and well, and there's a certain amount of trust and access that I can have to legislators, but when they really start to engage and the message starts to sink in, is when we involve our clients and our employees, the ones that are delivering care, our families, in our advocacy efforts as well, because they are the ones that firstly can vote for the legislator and keep him or her in office. And they're the ones that are really impacted every day, and they can tell kind of the most compelling stories. So with Hearts for Home Care, we have kind of a multi-pronged approach of using all kinds of different tactics to get to our legislators. And the great part about our program and the way that we've set it up is it's really a continuum, and you can be kind of as involved and get up front and personal, or as distant as you want to. So anything from just helping by completing an action alert and emailing your legislator. We make it easy by writing the majority of it for you, and you just kind of have to put in your address and kind of click send, and that message goes to them. Or writing, a personal op-ed or a letter to the editor, which is of course a little bit more personal. People tell their stories in there, all the way up to hosting a home visit, hosting a legislator in their home to show and live home care for a little bit. That's really been our most effective tool we've seen. Once legislators get into the home of these medically complex kids and see the dining room turned into a mini NICU, or the den turned into the bedroom for our client because they can't get up the stairs or whatnot, that they never forget that. It stays with them for years. I have interacted with legislators that they went on a home visit 10 years ago and they're still talking about it. And the great part about the technology that we have available is not only can we bring these kids home and take care of them effectively, and we kind of talk about that with legislators, how much that's changed and how safe kids can be at home, But with COVID hitting, we've transitioned to doing these home visits online as well. And that's been a really new experience for our legislators. And we found that they're really enjoying that and they're liking that experience because it's not only do they feel safe and they're in the comfort of their own home, but there's not a lot of people doing things like that these days. So it's having kind of an additional impact, not only seeing what's going on in the home, but just almost the novelty of it as well. And we're seeing that it's again becoming very, very effective. So that's a little bit about Hearts for Home Care and what we try to do. We have a very big and great reputation on the state level as well as the federal level, especially in Pennsylvania. And we're always looking for more people to join us. So we have some ways to get involved as well, or at least become notified. You can kind of get our alerts and understand what we're advocating for on our heartsforhomecare.com. That's our website. We have email advocacy@beata.com, and of course on Facebook as well, and a phone number there if you're interested. And just like you were saying, you are, someone said that you operate with the understanding that these medically fragile kids become medically fragile adults. Hearts for Home Care spans that gap as well. We're advocating, of course, for pediatrics, but we also talk about the issues of transitioning into adult care and talk about our clients that we have on the disabled adult and our senior side as well. So it's a nice continuum of home care advocacy.
Thanks so much, Laura. So as all three of you were talking, I had some questions forming in my head, in addition to the questions that I already had sort of anticipated asking. Dana, I want to come back to you for a moment. You talked about, so I feel like maybe a good progression would be just how we did it now. There's, sort of, Dana, you work really closely with the patients directly and their immediate needs and the family's immediate needs for coverage, for authorizations. And Erin, you get more into the state level and bringing folks in who are utilizing the services. And Laura, your group does that, as well as giving providers and the nurses the opportunity to engage as well. So I think the three of you, wow, we did a good job here pulling you guys together. You really span the realm of how almost everyone in this industry can really get involved. So Dana, I am shocked. I mean, I didn't know Pennsylvania Health Law Project existed until I walked into the Nursing Summit last year, and I had been battling issues with nursing coverage and authorizations and things for years at that point. So now that we have an audience, what would you say the folks out there could do to help make sure that the individuals they're serving are aware of organizations like yours?
Yeah, thanks, Megan. That's, a sentiment that I hear all the time. Every parent, every caregiver that I talk to almost will say to me, I didn't know you existed. And before I came to you, I didn't know that I had, options to fight this insurance appeal. I didn't know I had somebody to kind of stand in that ring with me and fight that battle with me. So what I would say, I guess there's two pieces. One is for the families on our summit today. I really encourage you to know that the Health Law Project is here to fight that battle with you, and you don't have to do it alone. There are very strong legal protections for our kids on Medicaid. Basically, the insurance company has to cover any medically necessary service. So if we're going in there to try to prove that this skilled nursing service is medically necessary for your child, we're going to work with your doctors, we're going to work with the home health agency, we're going to work with you, we're going to work with your child's school, and we're going to gather all of the information that we need to go in there and prove that these services are medically necessary so that your child or your loved one can stay at home where they belong. It's part of the thread of what I do. I've been doing this work since I got out of law school and started work at the Health Law Project. I've been doing it for almost a decade now, which is kind of strange for me to say, but it's just, I've sort of found a home doing it. right? So it really is weaved into the thread of what we do at the Health Law Project, and especially me. For the providers and nurses, whether you work in management of a home health agency or if you're a shift nurse yourself, you're really our ears on the ground. So we get so many referrals from home health agencies, from nurses. I get calls from nurses. Dawn mentioned this earlier, that she does a lot of calling on behalf of her kids to help them access social services that they wouldn't otherwise access. And that really just hits the nail on the head. We wouldn't, I don't think, exist if it weren't for the providers and the nurses who are superheroes out there saying, hey, call the Health Law Project. You have a right to file an appeal. Once they get that denial notice in the mail, you know, the family might feel so flustered, might feel very confused by the notice because they're not well written. Like, let's just say that out there. Sometimes they're not very clear, and they don't, the parent just might not, or the family member might not understand, hey, I have a right to appeal. So we really call on the nurses to do that kind of on the ground work in a sense for us, and we really are appreciative of it.
And just to sort of stay on the topic for a little bit of the direct advocacy for immediate needs and rights. You mentioned earlier doing trainings on proper documentation, and it made me think, given that all of us who have a loved one, pediatric, adult, are going to encounter denials that don't make any sense, given the need we know that our loved ones have. What are some habits you could throw out there now that we should all be engaging in to help preset ourselves up for success when we get faced with those obstacles?
Yeah, so some of it is definitely easier said than done on the front end. It really, in my experience, comes down to having a good support system around you in terms of your continuum of care. So having an engaged primary care physician's office is essential, really. I mean, the first thing I do when I get a denial is I ask to see the doctor's letter, because that is the backbone of the entire appeal, and the request to the insurance company has to be pretty strong in terms of showing that the services are medically necessary. But when that request or the documentation is not sort of up to snuff, that's when the denial happens. I mean, sometimes the denial happens when the documentation is there. Well, you know, that's something that you got to be frank about. But a lot of times what we do is we look at the doctor's letter, very first step, and we say, how does it look? You know, does it really call upon all the different elements that need to be in there? So it's not just sort of a stock letter. It needs to be, this doctor understands the patient and understands the client's needs, and also understands the family dynamics, because that comes into the legal standard that we're working with, whether a parent is available or able to provide the care. So that's the thing I would say is probably most important. And then the second piece is, we touched upon this earlier during the panel discussion, but open communication with your nurses and with your home care agency or home health agency. Because the worst thing is to see nursing notes and things like that have just gotten to the point maybe where they're not, the nurses maybe have been working with the child so much that they just know the care kind of second nature, and the nursing notes don't reflect it. And I think the thing that I always remind nurses when I'm training and things like that is, if it's not in the notes, it didn't happen. And that insurance company is going to want to see those nursing notes. So you might think that you're just doing this because it's part of your profession or part of, it's a requirement of your job or your career. At the end of the day, those notes could go over to the insurance company, because they can just ask to pull any day from whenever they want to see. And we want that to reflect the utmost care that is being provided in the home, to reflect reality. So those are my two pieces.
Thanks. I think that was great, because it not only set up what the families can do, but it also sort of segued into what the agencies and the nurses themselves can be doing to make sure that we're all ready to advocate in that individual and personal way when needed. Well, Dana, I think one more question for you before I pop over to someone else. We sort of talked about it already. Families and sometimes agencies and nurses we just don't know what voice we have in systems, and we don't know our rights. So are there some, in addition to Pennsylvania Health Law Project, are there some other organizations that you would recommend on a local level or even on a national level that when parents are feeling like they're not getting what they need, they should look out for or look to?
Yeah, definitely. Excuse me. So we get a lot of calls through our helpline from folks who might not know what we do. So we do a lot of referrals to other organizations. If it's not something that we handle, it's within our purview. An organization I would highly recommend is the Peel Center for special education type issues, and also Education Law Center. They do more systemic work. But we get a lot of calls from people, wondering, actually I get calls from nurses too, wondering, does the Health Law Project assist with IEPs and things like that? Like, might you go to a meeting with me? And that's, again, just back to what Dawn said earlier, that sometimes the nurses are the ones who are really going in there and acting almost like a social worker for the family and really coordinating what the family needs. So I would recommend the Peel Center. I would recommend Disability Rights Pennsylvania. They're an incredible organization that does work on a systemic level. They do some impact litigation, and they do some individual work through their helpline as well, for folks who need assistance with anything related to a disability, discrimination, accommodation, anything like that. They're a fantastic organization. But again, so many people do call us looking for referrals, and we have a wonderful intake system where if we can't help you, we will certainly try our absolute best to connect you with another organization. I think that's a great question, because that really, it could be easy to just say, well, we don't help with that issue, sorry, but we don't want the families to fall through the cracks, right? Like, that might have been the only time that they got connected to somebody who picked up the phone and actually, heard a little bit about their issue or problem that's going on. So we don't want them to fall through the cracks.
That's great. Thank you for that. And I just want to make sure that everybody knows that even though, I always come at things from a pediatric lens, so I try to make sure that I put on my adult glasses every once in a while. I mean, these are my adult glasses, but you know what I mean. But that Pennsylvania Health Law Project, your focus is pediatrics, but you have attorneys that do pro bono work for the lifespan, correct?
That's right. Yeah. Thanks for saying that. I certainly focus on the pediatric work. I also do some work with adults, but our organization as a whole, we have other experts within our organization that help with adults who have usually transitioned from the Medicaid for Kids world at age 21 into the adult waiver world. So once a child transitions from age 20 to age 21, they become, they age out of the child's Medicaid system, and they start getting services through what's called the home and community-based waiver programs. For a lot of our kids, that's through the Office of Long-Term Living. They handle the Community Health Choices waiver, and then there's also waivers for kids and for adults on the Office of Developmental Programs side. So the Health Law Project can assist with Office of Long-Term Living and CHC waiver service denials. That's our focus for the adults, is on the Office of Long-Term Living side.
Awesome. Thank you for clarifying that. So Erin, I'm going to jump over to you now. I just, just personally, I think what all of your groups do is amazing. But Erin, I think what you guys do is so unique, and you as a grassroots group of families brought it together so fast and so powerfully. It was just like the confluence of the right people at the right time. So if you could sort of talk to us about, some of the little lobbyists, folks who started the organization are more, they have a better proximity to DC, right? So they're closer to the Capitol. But Little Lobbyists has really stretched out the fingers and arms to embrace the whole country's worth of folks with healthcare needs and healthcare issues. And I think that when we medically complex parents and those folks caring for a loved one who has a lot of needs, we're just lost in a sea. We don't even necessarily, we can't pay attention all the time to the issues and the policies that are impacting us or that are putting us in jeopardy when we don't even know it. So, you know, it's really wonderful to see an organization that's doing so much proactively, but also just in an outreach aspect. So for families like mine, where I have a trach vent dependent child and I can't leave the house unless there's a nurse here to be with him, and we have family around, but none of them are trained to care for him. I wish I could pop up to DC or even go to Harrisburg more often. What are some things that you would say families who can't necessarily get out in person could be doing, particularly with little lobbyists, but also just in general, some things they could do to be active in the policies that impact them?
So I guess there's a lot. There's a lot to unpack there too. We do have, I just want to start by saying we do have a lot of families that do bring their nurses with them to the Hill. Obviously, we're not doing a lot of that right now with the pandemic going on. But we have kids on ventilators who come to the Hill. I know Ziamara, Elena's daughter, Elena's our founder. She was using a ventilator the night of John McCain's famous thumbs down outside at a rally. You know, yeah, it was a pretty significant evening. But
vividly remember it.
So I want people to feel like if you are comfortable going out with your child, there is no reason you cannot bring them to meet your senator. It's not that they're not, kids are allowed. And as we joke, they don't lock the doors. You can just walk right in. They work for us. So that would be number one, is don't be afraid to just show up and just talk with your legislators. They work for you. One thing that we always try to encourage families to do is to kind of be the happy warrior. We always, as I said, advocate alongside our kids. So it's really important that we start from a position of respect. We don't talk about our children as vulnerable. We don't talk about them as fragile. We don't talk about them as a third person. It's a we. So when Abby comes with me, she is just as much a part of the conversation as I am. And if they start talking over her head, she usually lets them know. So I just want to start there to just say the first step is to just know your own power. You are powerful. Your voice is powerful. Your kids are powerful. And they need to grow up with that sort of esteem that, you know what, people do have to listen to me. I'm a citizen here too. If you cannot travel, as many of us cannot right now, the first thing I would ask you to do is to fill out a story form, because that is where so much of our information comes from. And we do not feel comfortable sharing your story for you unless you've given us a story form and given us that permission also. But we try as much as possible to have families share their own stories. We try to use families' own words, and when possible, we try to get families to speak on their own behalf with legislators. We don't usually compile a whole bunch of stories and just tell them for families. A great example is recently we had an ask from Vice President Joe Biden for a local Lancaster family to come.
We did put Victoria in the spotlight for a moment earlier. I know you weren't on yet, but yeah,
and that's exactly how we decided to use Victoria, because she had submitted a story. We had worked with her before. She had come to Harrisburg with us before, and we were comfortable with the way she and her son speak about their story. Unfortunately, they said no kids under 13, so he couldn't come. But we look for the story to be something that is, what is being talked about at that time. His is obviously a healthcare story. We have other stories that might be a disability story, an access story, a special education story. And we also look geographically. There's a section on the story form for your zip code, because obviously, if you're talking to Senator Casey, we'd prefer you be from Pennsylvania. So that is an easy, well, it's not an easy way. It's a fairly easy way, though, to get involved with us. And sorry, my daughter's asking me for graham crackers while I'm talking to you. But it is a fairly easy way to make your voice heard. Right now, if you look on our Facebook and our Twitter, we have, I think we're at 89 days now, but starting at 100 days out from the election, we started sharing one little lobbyist a day. So we share a picture of one of our little lobbyists, and we share a little bit of their story that their families have given us. We rely heavily on, quotes from the families themselves. And we try to line it up with the issues that are, happening. Like today is the 55th anniversary of the Voting Rights Act. So we actually have a family from Pennsylvania featured today because their daughter is 25 years old and loves to vote. So, but these are the things that we like to point out to legislators too, is that our kids are going to grow up and you still work for them. They're going to make some decisions too. And they're going to remember how you voted and how you treated them. So the big thing that families can do is fill out the stories, but they can also participate in our call-in days. We have been, and please continue to, hammer the Senate on making sure that home and community-based services are included in this next COVID package. That has been a major uphill battle. But that fight is actually being led, of course, by our own Senator Casey, who I always say is my favorite senator. But there's a coordinated effort across the disability community and the healthcare community to make sure that HCBS is included in this next package, and that the FMAP, which is the amount of money that the federal government feeds back to states for their Medicaid dollars, it's a matching, trying to explain it simply, but it's the federal matching dollars for the Medicaid programs, that we can increase that percentage, especially during this crisis, because as we all know in Pennsylvania, Medicaid is enormously important, especially for home care, especially for our kids with disabilities. So those are the big things right now is calling your senator, calling your congressman, know who they are, put them on your speed dial. It takes usually 30 seconds to call them. You usually end up leaving a message, and right. They count. They count that. So those are some really simple ways, I guess, you could get involved. And of course, when we go on the Hill, you're always welcome. I mean, especially coming from Pennsylvania, it's not, I'm probably the farthest, and I'm probably 4 or 5 hours.
Yeah. So, even other things, so calls, what would you say? I will be honest, even as a, as a lady with a master's degree, I sometimes find it really difficult to find out who my legislator is locally or federally. Is there a way you would recommend families find out how to contact, like a streamlined way to find that out?
There is a website, and now I'm blanking on it. I can look it up and type it into the chat for you. But there is a website where you can, if you just Google "find my legislator" and you put in your zip code, usually your 9-digit zip code, because sometimes different sections of your town might be covered by different people. But of course, in Pennsylvania here, you have, oh, well, there you go.
I was going to say, surprise, Jana has it on a slide.
On top of it.
Just kidding, we know the answer. No, but for everybody else.
But everybody here, Pennsylvania, I assume, you have 2 senators. You have Senator Pat Toomey, who is a Republican, and actually does a lot of decision-making on Medicaid. Not usually in a favorable way for our kids, but keep calling him maybe. And of course, Senator Bob Casey, who is a disability rights hero in my book. But both, they have phone numbers. I often start with their DC number, but if you look on their websites, they have multiple offices, and sometimes you can get through to a human in a smaller office than you can in the DC office. They count those calls. They do, and they'll, you don't have to be eloquent. You don't have to make a huge statement. You just say, "Hey, I'd like you to support this," or "Hey, I'd like you to vote no on this. And I am a constituent, and I live in this zip code." That's really all you need to say, because they're just, they're just marking it down as one more call for this. So it's not as intimidating as it feels.
I think that's the misconception, is that somehow political advocacy has to be, it has to be something big, and it doesn't have to be. It feels intimidating, but it's not. I love one of the things Little Lobbyists does, if folks aren't familiar, every holiday or when there are big decisions coming up, they'll provide coloring pages and like templates of cards that you can print so that your child can send their local legislator a Christmas card or a holiday card or, a coloring page around disability rights and things like that. And I can't imagine that that's not received in some more special and unique and appreciated way by those folks.
We do some unique things too. We do trick-or-treating in the Senate and the House. We actually have our kids and sometimes our parents dress up in Halloween costumes, and we trick-or-treat. We go around the building, and they love it. The senators and the staff, they just love it because, how often do they see little kids trick-or-treating in their office? But it's also our in to say, hey, while we're here, let's talk about this. And we did a story time over the winter where we had a room in the Library of Congress, and legislators actually came to us and they read our kids' stories about, usually they were kids' stories about other kids with disabilities, which was just a really nice way for legislators to have that good one-on-one with our kids. And for our kids to kind of get to know these legislators and see them as not anything intimidating. I don't think any of our kids are intimidated by any of the legislators, actually, because they just, they're just one more adult. But yeah, we do some really fun stuff, and we do our darndest to make sure everything is as accessible as possible. We had interpreters for the story time, for example. Everything's wheelchair accessible. The Capitol is often challenging with wheelchairs. The elevators are small. And if there's a batch of us, it can take 2 or 3 shifts in an elevator to get us from one floor to another. So that's always something that we discuss too, is just accessibility. But yeah, having our kids alongside us and having them ask legislators for things is just enormously powerful. But we always try to keep it positive. We always try to make sure that our kids feel safe and feel respected during the whole process. One thing I always tell families is, if you write something on the internet about your kid, they're going to grow up and read it. And you might not like their response if you wrote something, in a way that, they felt was violating their privacy. So we always welcome parents to only share what their child would be comfortable with, not just what they're comfortable with. And same with our kids. As long as they're comfortable telling their own story, we let them do that. So
thank you for bringing that up. I think in this, particularly now, the more online we all are and the more virtual we all are, the less, the more blurred that boundary sometimes may get. So I think it is important, particularly for us as, for those of us who are parents, to recognize that, the privacy of our children as they grow into adults, but also how unique and powerful their stories are. So, being mindful of that, that tricky line. Thanks, Erin. Laura, I want to bring it around to you. I think this is a really unique thing that Beata does. I'm not sure how many agencies have an arm that specifically does government relations and advocacy in the way that Beata does. So it's an interesting situation there, and I'm excited to hear more about it. What would you say, given that your level of advocacy really does focus on not necessarily the individuals advocating, but the organizations that support those individuals advocating and bringing everybody in. So 2 things. I believe that someone had talked about, and perhaps it was you, Laura, video visits with legislators. I think, that was a really good point, because whereas we've always been we've always felt like, well, you have to go into their office, you have to see them in person, and maybe a video chat didn't feel as personal or as impactful. But I suppose you could call it a silver lining of COVID, is that this is all starting to feel more natural and more personal. So relying on that as a way to get more directly involved with legislators is a really good point. And it opens those barriers that perhaps some families felt about how they could or could not get involved, or agencies felt they could or could not get involved. Someone said in the chat, one of our parents, Gloria, and I wonder if you can speak to this, that she's encountered nurses who don't feel like they are empowered to get involved in this capacity, or that they are somehow, they may be in jeopardy of blurring a line or stepping over a professional boundary by doing so. Is that something you guys can work around with nurses and agencies?
Oh, it's a really good comment, and actually something that we encounter as a government affairs team so often. It's a really unique and almost funny position to be in, because we, if you look, I think for the last at least 5 years, the most trusted profession that's been ranked out of all the professions that exist in the world is nurses. And that's by like the public in general. So in one respect, there is this incredible opportunity for nurses to have their voices heard, and for whatever they say to be listened to, and to be believed as true. And the counterpoint to that we've run into is that nurses, by their very nature, are a little resistant to getting involved in advocacy and politics, and in government, because at least from what I've encountered, and this is just my personal experience here, so I'm sure it's certainly not true for everyone, but people go into the profession of nursing because they like that one-on-one care. They like the one delivering the care. They don't want to be the doctor necessarily that wants to see 30 patients in a day and just check a couple of boxes, and it's not as personal, it's not as connected as the nursing profession is. And because of that, not wanting to be like a cog in the wheel, but really make a one-on-one difference, that doesn't translate well into dealing with bureaucracy, government and bureaucracy and all of those pieces. So at Beata in particular, we spend a lot of time and effort educating our nurses and making them feel empowered, having them become part of the process, and making sure that they have that opportunity. I think there's also some additional wariness because of HIPAA, and maintaining that confidentiality and those kind of pieces. So I would say, as far as parents and what families can do, is encourage their nurse to get involved, to tell them how unique and how powerful their voice is. And either, there's a couple ways at Beata, for clients that want to get involved themselves, we have a consent form that kind of helps allay any of those fears that, we can talk about these kind of things, we can share those stories. So that's certainly an option as far as making it official. But nurses can talk about, who they care for in generalities, as long as it's not going to be identifying information. They can talk about the experiences they have, that they are doing right now or have had. And, they are able to do those kind of things. And I think it's just a little counterintuitive. The other piece I will say personally that is not necessarily associated with Beata or Hearts for Home Care, that I've always been an advocate for ever since I was in college, is placing a greater emphasis in nursing schools on learning about Medicare, learning about Medicaid, learning about how their profession is going to be influenced by the government, because they're licensed, and there's the Board of Nursing, and there's so many things that impact how they deliver care on a day-to-day basis. It's so important to know that they need to weigh in on it. In the state of Pennsylvania, and we're pretty good. It's still abysmal, but we're pretty good. We have 2 nurses that serve in the legislature. For a while, it was 0, and then it was 1, like kind of way back when. But we don't have nurses either running for elected office, because it's just, again, it's that kind of counterintuitive of like, well, I'm a nurse, I'm not a public servant. Like, you're a nurse, you are a public servant. That's like the epitome of what you do every day. So, we've encouraged and helped wherever possible. Being a nonprofit now, we're limited in participating in political activities, but letting nurses know that that not only they have a voice, they have an opportunity to be involved in politics, to run for elected office. And when they do get elected, we make sure that, when we were not a not-for-profit, we made sure that we supported those nurses and kept them in office and kept them rising through the ranks. So their voices were even more influential. And right now, even though Beata can't do that type of advocacy, there's a trade association on the state level that represents home care providers, and also on the federal side that represents home care providers, that can do that kind of work and that can contribute to nurses that are in office or running for office, and help get more of them. Because the more nurses I truly, truly believe, if we had a Congress full of nurses, we wouldn't be having any of the problems that we're having today. Because not only on the COVID side would they be able to actually make good decisions and move us along, but they just naturally are collaborative and want the best and would be able to work across the aisle, I would presume, pretty seamlessly. So yeah. Again, that's my own personal opinion, but I hope that helps a little bit.
Yeah, absolutely. And I guess I would say, you sort of said Beata has a unique, you have a unique setup. And that's a sort of a pro and a con in how deep you can get involved in the lobbying side of things at this point. But what would you recommend agencies who maybe necessarily aren't as big as a Beata, or who haven't been around as long as Beata and the connections? How could smaller agencies, or agencies that haven't previously maybe paid as much attention to all the legislative things happening that impact the ability for them to give appropriate care, how would you recommend they get more A, informed, and B, involved?
So the biggest thing I think I would suggest, and this can be even done on the family side as far as encouragement is concerned, is because we have those other organizations that represent providers, joining those organizations, and if they're already a member, becoming more active in those organizations is essential. The Pennsylvania Home Care Association is probably one of the strongest state associations of home care in general. We have a separate pediatric cabinet of providers that are mostly pediatric providers that get together and talk about issues that are coming up. We work with PHLP on a regular basis, and there's been a greater emphasis on getting more families involved. They came out with a magazine specifically for pediatrics, oh my goodness, in January, sorry, I had to think through when that was, about pediatric home care specifically, questions you need to ask, just all kinds of really great resources in that. And we've distributed that to legislators' offices, to the governor's office, and that's been an incredible resource for new families kind of getting their feet wet of pediatric home care. But it's a great tool as well for nurses or for providers. So if you are a smaller provider, getting involved in something like the Pennsylvania Home Care Association, national level, the National Association for Home Care and Hospice, those are both really great and strong organizations that have been around and are very well respected. When new legislation or regulation is coming down the pipe where there's opportunity, they go to those trade associations and say, like, what do you think about this? We're thinking about doing that. So before things are even proposed, they are and their members are able to influence what this looks like and make sure that we are raising the standards of the industry, which ultimately go towards, you know, protecting your families and protecting your kids and making sure that they're getting the care that they need.
That's a great point. You know, PHA, the Pennsylvania Home Care Association, I don't know if you were on the presentation yet, but earlier on I had talked about House Resolution 501, which is a resolution that pediatric shift care nurses are a valuable and necessary workforce. And, you know, I think that while it doesn't have necessarily any action behind it at the moment, I think it's such a wonderful way to sort of lay the groundwork for building off of that in all of these solutions that we're trying to creatively implement. So HR 501 was, my understanding, the Pennsylvania Home Care Association was actually really instrumental in creating and getting the legislators to sign on to that piece of legislation or that House resolution in Pennsylvania.
And that resolution was supposed to kind of be connected to the release of that magazine that came out.
Yes, the Care We Share. Yeah.
Yes. COVID kind of screwed that up a little bit. But,
I know, yeah. But I think that's a really good, that's a really good example of how the, organizations or agencies, for-profit entities, when they're connected with organizations like Hearts for Home, or when they're we're connected with the trade organizations that are directly impacting legislation, or at least being part of that that process, that is a good step. That's a good stepping stone for getting there. So I'm glad you brought that up, because that House resolution, it's one of those pieces of progress that I think last year, this time, I don't know that everybody was talking about the shift care shortage in the way that we are this year. So all of those elements just point to how clearly this is a devastating issue for very many families. It sounds like we're a small population of a small population. We're the medically complex side of an already small disabilities population. But when you think, I know the only number I know off the top of my head is that I think someone else correct me if I'm wrong, 3,400 children across Pennsylvania are eligible or authorized for shift care nursing. Is that right, Dana? 34?
Right. Good job. Good memory.
Over 3,400 children. Over 3,400 children are authorized for shift care nursing across Pennsylvania. So that doesn't even get into the adult side or the senior side. So you can imagine how many thousands upon thousands of individuals are reliant on shift nursing. So this is not as small of an issue or small of a population that's impacted as one might think off the bat. So thank you everyone for all of those comments. We have 15 more minutes of this session. I do want to do a quick poll. If I can get, my computer keeps choking on it a little bit. We'll see how it goes. This is a very quick poll for those who are in the room. How important do you feel your family's healthcare and community support issues are to legislators? Very important, important, slightly important, neutral, slightly unimportant, unimportant, or very unimportant. And we'll give about a minute to do that poll, and then hopefully if there's any questions, or if anybody wants to have a direct conversation or bring up a direct point in the chat or raise their hand to talk, we're happy to open it up a little bit. So it looks like so far we've got 28 respondents, 29, and the most people so far have said that they feel that their family's healthcare and community support issues are unimportant. It looks like the majority, though, lean toward the slightly important, important, and very important side. Things are moving around a little bit. But it's looking, from neutral down to very unimportant, for neutral up to very important. It's almost 50-50. So there's obviously you know, there's a variation of experience and a variation of how heard families are feeling, I would imagine. And some of that may come from how much access they have to their legislators or the legislative process, how much understanding they have of it, and how much not only are they reaching out, but how much that process is attempting to reach out to them. So I think, you know, what I'm hearing too is what we can all do is really encourage everyone involved to push their own legislators to really pay attention to this population and make it so that they're asking us for our input and working to, as Erin said, they work for us. So making sure that they remember that they work for us too, and our issues are just as important as everyone else's. Amy, did you notice anything coming up in the chat?
I just had a comment that this has been a very great discussion, and the information about resources is also very helpful. If anyone does have additional questions for the panelists, you can go ahead and enter in the chat or raise your hand to be unmuted to ask your question directly.
You know, I'll just say, as far as with the poll that you guys just did, legislators make decisions on everything from puppy mills to fracking to education on a day-to-day basis. So they often operate as squeaky wheel gets the grease. So if you're not squeaking, they can't hear you.
That's a really good point. We have another comment that says, "Thank you, this is so helpful." I'm really glad that it seems like this information is hitting in a way that may be not just illuminating, but inspiring to some folks out there, hopefully. While we check the chat for some Q&A, I want to hit the slide. Oh, sorry, go ahead.
I was just gonna say that we do have a person that would like to ask the question. So Catherine Stokes, I'm gonna unmute you.
Hang on, Catherine, give me, I just realized we missed a slide. Dan, if you don't mind going to the voter registration information. So before I open it up to everybody, we just wanted to remind everyone that one of the very, very, very necessary ways that you can be part of the process is to make sure that you're voting and to make sure that your children who are impacted by this and who are old enough to do so are voting and aware. Right now, obviously everything is in flux with COVID about what our options will be, not just on a actual state level, but just on a personal level. You know, some of us may feel comfortable going to the polls, others of us may not. Some of us may be able to not be able to get out of the house to go to the polls. But you have to register to vote by October 19th. You can apply for a mail-in ballot if it's difficult for you to get to the polls and or you're trying to limit contact as much as possible. You can apply for a mail-in ballot by October 27th. Pennsylvania is a state that's allowing mail-in ballot regardless of if you have a reason to be absentee. You can find your voter registration status at the link on the slide, which will be on the Pennsylvania Families Need Nurses Now website later today. But we're also happy to share that in the chat as well. And if you need help with your voter registration, there is a helpline, 877-868-3772. So we do strongly urge everybody to make sure that they're registered to vote, to make sure that their vote is heard on a local level, on a state level, on a national, on a federal level. This is a really, this is crunch time for those of us who have healthcare needs. It's a really, it's a hot button issue, and it's there's multiple ways to register to vote. You can vote online, or I'm sorry, you can register online, you can register by mail, you can register in person. So if you feel more comfortable registering in person, even at this time, that is still an option as far as we know with your county office. These links, again, will all be available later on our website. And then next slide. Now we're wrapping up. Questions, feedback, suggestions. Catherine, it's you.
Catherine, you've been unmuted. You can go ahead and speak.
Okay. Hello, everyone. My I guess, statement is I have for multiple times approached
my senators, council people, just for, I'm going to say basic for a lack of a better term, even right here in Philadelphia County. What I've come to realize is that many of them don't understand the world that we live in, and I think are afraid of the unknown. And I have offered to sit and let's just have, again, here I go with just a conversation. Let's have a conversation, because you want us to vote, and it segues right into voter registration. You want us to vote for you, but we can't even get an accessible playground in our community because you don't want to sit down and talk to us because it's the unknown. If you think it's scary for you, it's scary for us also. But we have to be able to come to the table as adults and as parents and have this hard conversation. I've invited them to my home and no one comes. I need to get you to come on my side of the fence to understand what my life is like. And it's not always, you know, a walk in the park. It gets complicated. And you can't possibly be fighting for what I need and what my family needs when you're afraid to come over and find out what we actually need. We didn't need, I'm in West Philadelphia, we did not need an outdoor roller rink. We needed a accessible playground. And nobody uses this thing. So it's frustrating because I can't take my daughter to a park and put her on in her wheelchair on a swing. But it's something that's needed. And if you ask them how many individuals, children or adults who have intellectual disabilities that are in your zip code, they can't even answer that question. And that's appalling to me, that you can't even answer that question.
I think that's a great
Thank
point.
you, Catherine.
I don't know that we have any legislators on the line right now, or that we have anybody from the Philadelphia legislative process. But that, you know, what you said, Catherine, they don't know how many people live in their district that have special medical needs or have special and complex needs. And I think that's that's a good point, that we have to be the ones to tell them. And there are organizations like perhaps Vision for Equality and that can tell them, or little lobbyists that can filter out some of that data so that we can give that to them. I think Laura might want to jump in here.
Yeah, we do have data available as far as how many pediatric clients, at least that are BAOTA clients in each of the districts. And anytime we bring that forward to a legislator, they're always kind of taken aback. But I would say, you know, in my time, I have run into those legislators as well who are very uncomfortable with going into the home because they're sick people. And, you know, one thing I wanted to express to everyone on the call today, you know, home care has always been difficult to get people involved in advocating because a lot of our clients are homebound, right? Well, right now, everyone's homebound. We are all on the same playing field in terms of advocacy for the first time in probably forever. So you guys have such a unique opportunity right now because, you know, you're used to kind of having these restrictions, having these kind of things that you were dealing with on a daily basis. So legislators are beginning to be more open to things like video chats, and it's becoming more the norm, especially, even though I can tell you, I've had a lot of video calls with legislators who, you know, are generally not very tech savvy, but they're figuring it out and they're generally liking it once they can kind of get a handle on it. You may have to schedule an extra 5-10 minutes to get them going. But you have such a unique opportunity right now because no one can go anywhere. And those legislators that maybe said no before of going in the home, maybe they might be a little bit more comfortable with the video chat because you will have that screen, and you know, they have that screen and they're in their own home. So they may feel a little bit more comfortable because they're in their bubble, if you will, than just going to somebody's home and being in a completely kind of foreign environment. And at the same time, they can still get that kind of flavor and feel. And we've worked really hard to put together a program for these kind of virtual home visits. So legislators do get that same kind of feeling and vibe that they would have gotten by being in the home as far as how we demonstrate using some of the equipment or whatnot. But I just wanted to put that out there that, you know, I know it's always been incredibly difficult for families with medically complex children to advocate and to take the time out. But at least, you know, with us being virtual, that one barrier has been removed, and it's something to level that playing field.
Yeah, and you know, you can always do a tour and a tutorial right there through the video. So I'm happy, you know, I'm sure I'm sure all of us parents are on the phone or happy they're on this call or happy to do a trig change on a video call with a senator if that's what it takes. We do have a suggestion. Oh, sure, go ahead.
I just wanted to address the question about accessible playgrounds. There is something to be said about peer pressure with legislators. We have actually hosted play dates with legislators at accessible playgrounds, which have turned into, you know, their Facebook pages. Love it. And then other legislators see it and they're like, hey, now wait a minute. But if you don't have an accessible playground in your district, you can't do that. So there is something to be said with the pushing them by encouraging their peers who have already done something that you like maybe a neighboring senator has an accessible playground in their district. And if you want to reach out to us, we have set up play dates with legislators in the past, and it's fun. And it's a great way to kind of bring them into our space and have them meet our kids in a place that doesn't intimidate them and makes our kids comfortable, and then they can hear us out on our issues. So don't be afraid to use their friends against them if that makes sense. I mean, peer pressure isn't always a negative thing.
Keeping up with the Joneses translates to politics too. So Liz Healy in the chat. Hi, Liz. She had a great suggestion. Liz Healy is one of the co-directors of the Imagine Different Coalition. So I'm really glad she got to join us. And she wanted to point out to everybody that you should apply now for your vote by mail ballot so that it helps the Department of Elections in your county and helps the U.S. Post Office not get overwhelmed at the last minute. And you mail in your ballot as soon as you receive it in early October to make sure that it gets to its destination effectively. I know someone else had brought up in a previous conversation that we had during planning that many counties also will be offering drop-off points. So if you're a little nervous about your vote not counting because it didn't get there by mail, your vote by mail ballot in most counties can be dropped off at a physical location with low contact procedures in place. And that puts us at time. I'm not sure if we had another comment. Catherine said, I'll put the pressure on Erin. We need a playground. Thank you. She'll put the pressure on. She's going to put the pressure on. Not on you, Erin, but to you, Erin. She's going to put the pressure on. They need a playground. Catherine, good luck. I know if anybody's going to get it done, it's you. So I want to thank our panelists. This has been so educational and informative and just sort of, you know, it warms my heart to know that there are all these folks out there who aren't necessarily directly impacted themselves, but who are trying to make change for families like mine on all levels. So thank you for your part in that. And if there's any other information that you think that you'd like to share with this group, we're happy to post it on our webpage and our Facebook later. All right, everyone, if there's anything else, Amy, did I miss anything?
No, we're good, and we offer our thanks to all the panelists.
Yes, thank you. Amy's keeping me honest. Thanks, Amy. Amy from Vision is a local hero, by the way. So we'll take a break. We'll come back at 2:30. Our next up, I don't know if Dana, do we have a slide that says what's next up? Oh, I have it. Partners in Person-Centered Care is our next session. I hope that everyone on the call will stick around with us. Everybody on the webinar will stick around with us. Victoria and myself and some other folks perhaps we'll be sharing some tools, resources, and processes that we've developed and that we've collected from different families' experiences, different nurses' experiences, different agencies' experience, and we've tried to put together into one package or a few small packages of ways that while we wait for system-wide change to happen, we can all, as caregivers, nurses, agencies, and other entities, continue on that track of partnering in more person-centered care. So we'll hope you stick around. 2:30 is when we'll come back and start that. We'll go 2:30 to 3:30, and then we'll be wrapped for the day. So we'll do a quick break. And thanks again for everybody who's joined us so far. I hope this has been helpful to everyone, and go enjoy some beverages and a bathroom break.
Thanks so much. Bye, everyone.
Thanks, everyone.
So we're almost at 2:30. We'll be starting back up in another minute or two. I'm glad to see we still have participants hanging in there. Thanks. I know this is a long summit day, and when we do something like this in person, it just, feels a little more warmer, I suppose, and it's not as probably as strange of a marathon to run sitting in your own home or office. So I appreciate everybody sticking around for as long as you have. I think we have some really interesting, we've had some really interesting perspectives and information today. And hopefully what we share next is really helpful in moving some of the work forward in a very individual-centered way, a person, patient-centered way. I wanted to share Rose Andres, and I apologize if I am not saying your last name right. We had in the chat, Rose shared with us, thank you so much. Today has inspired me. I'm a nurse at a day program for those diagnosed with developmental disabilities. My individuals are all over 21. We haven't been back to our day program since March, and I've decided to look into a trach and vent certification program. I have a minimal amount of, my screen keeps skipping. Oops. Amy, are you able to say, okay, I have a minimal amount of experience, but I'm a fast learner. I'd like to become a pediatric home care nurse for those with medical as well as developmental disabilities. Developmental needs. Thank you to all for all of your time. I'm so glad that our director at Delta thought of me for this webinar. Take care and stay safe. I want to say two things there. There are a great many nurses who wear many hats. So for a person like Rose who's interested in becoming a nurse, work at a day program and work at nursing is a possibility. So that's one of the things that's a benefit to home care that nurses like. They have a level of flexibility so that they can maintain perhaps something else that they love, like working at a day program when they can come back. And while also providing care on a more medical level in another capacity. So we know a great many home care nurses who do home care and who also work in other fields. I want to just attend to one of the pieces of terminology that came up in that comment, and I hope I didn't blow somebody up by saying that name. There's no trach vent certification. There is no formalized training across the state for being a trach vent nurse. There is a specialty for being a nurse for developmental disabilities. And one of the things that I know Pennsylvania Families Need Nurses Now and other organizations, across the state hope to accomplish, that we are able to, through all these types of discussions, figure out more ways to train nurses in a more standardized way, particularly for high acuity things like trach vent for central line, so that when nurses go into home care and they are doing complex care in the home, that there's a level of additional training they've received that doesn't just live in the agency, but it follows the nurse from place to place, from environment to environment. So that being said, there are agencies that do, I encourage anybody who is looking to become a nurse, an LPN or an RN, to look into training programs that have any information around home care in their curriculum. And also when looking into an agency to work for, making sure that they have an internal training for trach vent, and talk to some of the other nurses who work there to find out how prepared they felt by that program. As we heard from Meg Mom earlier, she did receive training, but she didn't necessarily feel as prepared as she would have liked to have been once she was in homes, even though she worked for an agency that had an internal training program. So those are some distinctions. So for those who are in home care, or for those who are in home care adjacent fields that are feeling inspired, I hope that's, perhaps there are several folks that'll come out of this inspired to join the workforce. those are some things to consider. So I think that the terrain is going to change in the future, and we're going to have stronger training, and we're going to have stronger certifications, and we're going to have a much more stable career for you. But in the meantime, identify those agencies that are going to give you the training that you need. Initially, don't feel like you're necessarily you have to jump into only nursing. There's a balance there with home care. We love when people come in and that home care is their life, but but that doesn't have to be the case. It's a fairly flexible job if your heart is in it and your skill level is there. So I hope that answered not necessarily a question but a comment. And gave a little bit more information, and particularly for employers out there who are looking to recruit and retain nurses, to just think about that nurses are looking for some more specific training. So without further ado, I want to jump in and start our second session, our second breakout session, where we didn't really break out. We're all just still here in our rooms and whatnot, but we're excited to talk to you about being partners in more person-centered care, and providing tools and resources for providers and caregivers and nurses to improve care at home. Next slide. Your panelists today are me. So you've met me. I can tell you a little bit more about myself. There's not much more to say. I'm Megan Lichkowski. As I mentioned before, I have a background in nonprofit management, and I ultimately transitioned into working one-to-one with children with autism, and particularly nonverbal children. So I did some early intervention work around ABA and behavioral interventions for a while before I decided to become a certified special education teacher and received my master's in education. And then I became a medically complex mom. So the career path was a little derailed, but my knowledge base exploded. So that's a little bit about me. And I currently serve as the program manager for PA Families Need Nurses Now, which, as you may know, is a program of Vision for Equality, and we're the hosts of the summit today. And my co-presenter today will be Victoria Salerno. Victoria.
Hi.
Hi.
So a little bit about me. As Megan said, my name is Victoria. I am also a medical mom. That's my most important job. But my background also is actually in education as well. Did a few other things in between there before I had my son Cole, who is 4 years old. His kind of broad umbrella diagnosis is mitochondrial disease. He requires 24/7 hospital level care at home. He has a central line, feeding tubes, a Dexicon, all kinds of fun and unique equipment to use. And our nurses here, I have 20 hours a day of shift care to help take care of him at home. And with Megan, I am also part of PA Families Need Nurses Now. As Erin Gabriel said earlier, I've done some work with Little Lobbyists. I'm also involved with the United Mitochondrial Disease Foundation. So I do a lot of advocacy work, which is something that I love very much. And I'm very grateful to be here today and to help Megan. Oh, there we go.
My screen was not letting, or my cursor wasn't letting me go to the mute. So you know what, Victoria, everybody has heard my voice for so much of today. Do you want to sort of take the lead here and talk about you're now muted, haha.
Oh, have to love Zoom sometimes, you know?
And I know, and sort of just introduce everybody to sort of the difference between the dyad partnership between the nurse and the parents, and the importance of that triad that we've talked about.
Sure. Yeah, I think, and this is conversations that we've had in a multitude of different groups that we've been lucky enough to be part of now. I think a lot of times people focus so much on the relationship between the nurse and the caregiver and the child or the client, which is obviously incredibly important. But a lot of times people leave out the relationship of the agency and how the agency fits into this. And as Megan said, we prefer to kind of look at it more like a triad. All of these pieces feed in together with each other and are equally as important in creating a symbiotic relationship, so that the agency benefits and the nurses benefit and the families benefit all the way around. It's important to consider all of these pieces and how they play into each other. And all of them together are what create the home care system that we are all part of. So, you know, obviously there are some bumps along the way to getting quality home care on the agency side of things. There's sometimes a lack of clear and consistent communication. As we've seen in the nursing survey, nurses often feel like they are not valued. There's that stigma that Megan brought up earlier today as well with home care nursing, which feeds into this problem as well. Often we see nurses who are not well trained or experienced with the specific needs in home care, because as we've talked about all day long and various times, home care is a completely different animal than what you see in a hospital or in a long-term care facility. So it's not maybe so much that they don't know the skills, but they've never seen the equipment that we use in home care, or they've never been exposed to a home situation, which is run very differently from, you know, a hospital. So they're not necessarily prepared for that when they come in. We have issues with attendance. Nurses showing up for their shifts, and also commitment issues. And sometimes, you know, there's different things that go on in home life or, you know, outside factors. But, you know, our children, regardless of what else is going on, they still need care. It's not the same as calling off at a, you know, job elsewhere where maybe they have someone to sub out or someone to cover for you. That's not how home care works. So it's really important, you know, that nurses understand how important it is to be there and to be committed to a case. And for the family, obviously there are bumps there as well. You know, not everyone lives in an area where people feel safe. Sometimes, and you know, we've talked about this earlier today, caregivers don't know what they can and can't ask for. So they might sometimes make some unreasonable requests of their nurses. I think Catherine mentioned earlier today, you know, hey, can you watch my kids? I'm going to take a walk. That's, you know, not a reasonable request, but a lot of times families aren't aware of that. And sometimes there are just things going on within the family's life that's not conducive to a healthy and safe work environment. And it may be no fault of the family. It's just the things that are happening right now. But these are all things that impact the nurses and the agencies and home care. Something that, you know, we've talked about often are, or is the label given to families who are going through these things, and they're called problem families. But really, they're not problem families. They're families that are facing significant problems. They're going through things in their lives, which we all do. And it's not that they're problem people, it's that these things that are impacting their lives make home care more difficult for them. Next slide, Dana. Thank you. So the first thing that we're going to talk about in so far as solutions, this is something that was discussed and worked through in the OMAP workshop that Sally Kozak spoke about earlier today, and Megan has also talked about. One of the groups, the caregiver nurse relationship group, was focused on ways that we could make this triad between the agencies and the nurses and the families a better situation. And this is actually a program that I have piloted, but I'm also working with others on this as well. So it's a family council model. And a lot of times, I think, which has also been a theme of today, the family voice is not brought into all the situations where it should be. So this is a way for agencies to get the families involved in the day-to-day. So what the Family Council does is it fosters partnerships that create that triad. So between the agency, the nurses, and the family. It looks to identify and offer resources within the community that the agency is part of. So they could bring resources, solutions, peer-to-peer support for new families or existing families. And they also can support the agency in identifying and implementing new procedures, training, and outreach. So those are kind of the goals of the Family Council, and I'm going to explain the structure and everything as well behind that. So the Family Council is set up to have families, obviously, that are part of that agency, a diverse group of families that can be there for the agency, for the nurses, and also all of the families. And these are some of the ways that we're utilizing the Family Council, but there are plenty more, and I'm sure people have other suggestions, which is great. Like I said, we're fine-tuning this model, so we're open to feedback on that. So, but some of the things that we've done offer new family training and support. Being a medical mom myself, I can tell you coming home from the hospital for the first time with my son was completely overwhelming. I didn't know how to set anything up. I didn't know what I needed. I didn't know what was expected. It was completely overwhelming. So the Family Council can offer that support to a new family and be there when they come home and talk to them as someone who's gone through it. Now, as a mom of a child with a central line, I can help someone else coming home and say, you know, these are the kinds of supplies that you need to have. And this is a way that I've set it up that's worked well for our house, but let's help identify ways that might help your home as well. So that's just one option. They can offer peer-to-peer solutions for extenuating circumstances. So I think we've all been there. We've had things going on within our home that are difficult to deal with, and agencies have, you know, obviously had to deal with this, nurses as well. And sometimes feedback is taken better when it's coming from a family member, someone who's been there, versus someone outside the situation talking about it. So one example of that would be we had a family that was having a really difficult time with transportation, which was impacting their appointments, their ability, you know, to have their nurses there. So the Family Council was able to get those resources for them within the community that could help them with transportation. And they were very receptive to that solution. But that's, again, just one example. New nurse training is another thing that we can do. There's no one who can talk about the home care experience from a family perspective better than the families themselves. So one of the things that a Family Council could offer are family members to come in when you have new nurses training and talk to them about what the home setup looks like and expectations and ways that nurses can foster a positive relationship with their clients. Policy and procedure updating, again, having family input into agency policies and procedures can make things so much smoother for that relationship between the families and the agencies. We can report back as the council to the agency on things that families are interested in, and vice versa. We can go to families with things that the agency is considering before they actually implement new policies. And as I said, through all of this, relationship building is the most important thing. So we kind of act like that liaison in the middle. Yeah, so that is kind of the applications that we're working with now, but there are definitely many more that can also be used. Next slide, Dana, please. So as for our structure, and again, the nice thing about the Family Council is you can structure this for any agency size. So it doesn't matter how big or small you are. This is something that you can do with just a few family members and use the applications in smaller ways, or you can make it as big as you want to make it. So I feel like it's a very diverse model. But it's something, the way that we have it structured now, so the families are nominated by their clinical managers or their nurses, and we try to make sure that they're representative of the demographic that the agency serves. So you want to try to make sure that you have families like Megan who have a trach vent child, or families like me that have a central line child, or, you know, behavior and mental health as well is also really important. Different areas of the communities as well. People who have been with nursing a long time and newer families as well. All of the families that are nominated have to sign HIPAA forms, and also we have them submit for clearances as well at this point. And one important thing to note when we do this, the family council is not given any identifying information about the family unless the family signs a waiver that we are allowed to have that information. So there's no point at which a nurse would come to us and say, oh, family A, this is happening. They would come to us and say, here's an issue that's happening within the client base, and we try to offer solutions to them to go back to the families. So I did just want to point that out. Next slide, please, Dana. Currently, we do monthly meetings right now. Of course, it's a Zoom situation, but it's made up of the family council, members of the agency, staff, and nurses. And the way we kind of break down our meeting is a third of the meeting is old business. So we're kind of going over things that we had talked about previously, anything that was outstanding as far as, reports that were due or solutions that we needed to provide for people. We make sure that that is all caught up and ready to go. A third of the meeting, we talk about new business. So if our nurses bring questions or the families bring questions, that's the point where we handle that. And then we also try to always have some sort of training, because part of our job is to provide resources. We try to invite the community to get involved and to present to the council about things that they have available within all of the different communities the agency serves. That way we can provide these resources to the families, the agency, and the nurses. And as I said, this is easily scaled to fit the agency size. So don't feel like, you have to have 30 family members involved and make it a big thing. Maybe you only want to have a meeting once a quarter, that's fine. But the most important takeaway is to have families involved, because it's going to strengthen that relationship between all of your nurses, the agency, and your families. And we've had great success with families actually staying with agencies, because situations get resolved that may have otherwise not happened. So you have retention there on the agency side, and also nurses staying because they're able to find more resources to provide for their families, which is really important to them. As we've discussed today, the nurses have a huge heart and they just want to help. And this is another opportunity for them to be able to provide for their clients. So as I said, the positive relationship is the most important thing, but also retention of the nurses and your families, and also community involvement. It's great for the agency. It gets them known within the community with all the different resources. It creates a networking partnership as well for them with everything that's available in the community, which has also been a great positive outcome of this as well. We do have a whole form set up, a whole model for this. That is something that we will have available for you guys if you're interested in more information on it. But this is just one of the many resources that have been discussed within the OMAP workshop that we think could be valuable. Megan.
Thanks, Victoria. Yeah. And this is, Victoria mentioned that we did recommend this one. We were fortunate to be a part of the OMAP Shift Care initiative that Sally Kozak talked about earlier. And this was one of the recommendations that the families brought forward. And in that capacity and in that group of professionals, there was a really high level of interest from the agencies and even the MCOs, the insurance companies who were involved in that process, wondered how they might, sort of be a part of that. So it seems like the spirit of person-centered care is really there in the industry, but perhaps the tools and the processes just aren't. So this is, when Victoria came, when we all connected and prior to becoming part of the OMAP process that just wrapped, this is one of those projects that it was a grassroots project that a mom concocted, and she got her agency to, after some prodding and poking, she got her agency to get on board with it and give it a try. And lo and behold, months and months later, It's not just benefiting the families, it's benefiting the nurses, and it's benefiting the agencies that are involved. You know, questions I had around this model was, you know, how do we make it more centralized and more available? And, you know, part of what blossomed from that nursing summit last year again was PA families need nurses now. So when Victoria is saying we will have it available, she means PA families need nurses now. I assume you mean
Thank
PA
you,
families
Megan.
need nurses now will have it available. Yeah. So this is, you know, this is a model that Victoria created and that her agency jumped on board with to pilot, and that we as a group of Pennsylvania Families Need Nurses Now are tweaking and growing, and with Victoria's taking the lead on it, crafting it so that it is hopefully applicable across, as Victoria said, across agency size. It doesn't necessarily have to be for nursing agencies. It could be for home health agencies that don't necessarily provide nursing, but they provide home health aides and PCAs. So this is really, you know, it's another one of those tools and possibilities that we'd like to offer in terms of bolstering that partnership in care. So thank you, Victoria. I mean, thank you for that great presentation on it. And then also just thank you for, you know, sharing your brainchild with us.
You know, I'm very pleased to, you know, hopefully offer something up that could be helpful across the state and throughout home care.
Yeah. So I want to take a moment to do a quick poll. I know we don't have all of our attendees left, but I realized there was a poll that we didn't get to, partly because I am just not familiar with this process of polling. One of the questions that we didn't get to ask, and I hope everybody will indulge me in answering this one, is have you or a loved one, everybody who's left on the line, have you or a loved one ever depended on the care of a licensed nurse in your home for several hours at a time, what we call shift nursing? Yes, I myself have been dependent on shift nursing at home. Yes, my loved one has been dependent on shift nursing at home. No, but myself or a loved one has been dependent on other in-home care like a home health aide or a personal care assistant. Or no, neither myself nor my loved one has depended on a professional caregiver in the home. So we'll go for about a minute, let folks answer a question. So interestingly, so far, we're not at a minute just yet, but we are about half of our audience right now, half of our attendees have neither depended themselves or had a loved one who's depended on professional care in the home. So I just, you know, again, as a medically complex mom, it's always really encouraging to our population when we find that half of a group like this isn't even necessarily personally impacted, but here you are hours and hours later, still learning about this issue and trying to help us identify solutions and the ways that we can get solutions implemented. So that's really powerful for us to know, and I appreciate everybody who is taking part in this. So I'm going to end that poll for now. Sometimes it lets me to share the results. Here we are. Yeah, the most 52% said neither they or their loved one has depended on professional care in the home, but here you are with us today, so thank you. We are also excited to share with you another tool or process, procedure, however you want to look at it. Another sort of adjustable to your need resource that multiple families, I would say all the families who are still around, I think almost every family who has the capacity to do so sort of implements their own expanded plan of care. So in the shift nursing world and, you know, in other sort of direct care worlds, there's always a plan of care of some sort. And in the shift nursing world, in the direct hands-on medical care world, it's called the 485, the plan of care. And that is the medical care that needs to be provided for the patient in the home. Ideally, each nurse who is given the opportunity to go out to a household that is in need of nursing in their home is given this plan of care to peruse before they get there. It's not always the case. Some agencies have different procedures. But a lot of times when a nurse comes into a new home and a new work setting with a new family and a new patient, all of the information they get is specifically just what meds does that person get, what is their diagnosis, what are their hands-on care needs, you know, are they incontinent or not, do they have a trach, how often is the trach changed, things like that. So as we all know, there's, even for a very medically complex person, there's a whole lot else that goes on with that person and what their real needs are. So this, I think, lends into some of what we hear from home care nurses when they say they get into homes and they feel unprepared. Part of that isn't necessarily just that they feel unprepared by way of their training. They feel unprepared for that household, or they feel unprepared for all of the needs of that patient. You know, we would like to see the plans of care expand beyond just the focus on the medical, because in reality, every home care nurse knows, every family knows that when a home care nurse is on the case and when they're great and when they're good, they are caring for that whole individual. And you can't medically care for a person if you don't also know, you know, which stuffed animal calms them down when they're having a rough time, or, you know, what TV show they get to watch after they've finished their online PT session, because everything's online now. Or if they like tickles, or if tickles are a sensory issue for them, or if there are some behavioral needs or interventions that are being put into place because there's a potential diagnosis or already a diagnosis of a behavioral health concern or a mental health concern. So nurses walk in almost blind, other than, you know, knowing what they're going to draw up and push into a patient or feed a patient. So that's something we'd like to see change. And I think what I started to say was, a lot of families have their own sort of version of this. You know, I always joke, I say mine is like notes scrawled that are put on the pin board of the things that I know the nurses need to know beyond what's in their book provided by the agency, or their tablet provided by the agency. Whereas, you know, the Victorias of the world have like a beautiful binder that, you know, has like probably laminated pages. And so we all kind of do this in some capacity anyway. Not all families, many of us families. So we'd love to see this be a habit, if you will, until perhaps it becomes a system-wide adopted requirement. But perhaps for now, we just make it a really good habit to increase that culture of partnership and preparedness for agencies, for nurses, and for families to engage in this process of quantifying the needs of the patient beyond the 485. So it's a more comprehensive look. It's an expansion. If you go back just a sec, Dana. That was the word I was forgetting. I just want to make sure that we're reminded that, particularly on the pediatric side, that nurses are prepared for not only delivering the medically appropriate care, but the developmentally appropriate care. So that was the only word I was searching for. Thanks, Dana. If you want to click back in to the next one. So what we hope this does is that it focuses partners, meaning all the partners in care, on what the child could and should do. So including their goals, what could they do? What should they be doing? And not to say that there are milestones that are set in place for every kid, but knowing that that kid or that patient or that adult what are the things they could be doing that we're not already helping them do? What do they want to achieve? And what do they need to get there versus just what they can't do? Well, they can't get up themselves, so you have to help them out of bed. They can't get to the bathroom, so you have to change their diaper. Well, what can they do, and how can you help them do those things as well? It helps nurses hit the ground running with a better understanding of their patient and their new work environment when they walk in. So one of the other things that we like to include in a plan of care, beyond the 45 plan of care, is not just the extenuating patient needs, but also sort of a bio of that, the family makeup, and the household dynamic and household information that's important for nurses to know when they walk into their workplace. That's somebody else's private home where they sleep and shower and have to have all of their private lives play out with a one-person audience every day. So next slide. We do have a 3 to 4 page template that recommends what could go into a beyond the 45 whole child plan of care. And we sort of tout it as a resource for agencies to support nurses and a whole child family-centered approach to care. But this is certainly something families could take themselves and fill out for the agency and ask them to use it, and perhaps push them to use it with other families. It's something that could be utilized during intake or during meet and greets to find out more about the families. So you can see some of the categories to consider when creating a whole child plan of care. Is the household or family. So list of other household members. That's often important for nurses to know who they should expect to see in the house, and if there are other children. Pets. I can't tell you how many times we have cats, and I can't tell you how many times our agency has sent out nurses to meet us who are allergic to cats. Household allergies and restrictions on our end. On the family end. So if there is a child in the house that has a severe peanut allergy, that nurses need to know that they shouldn't come with a peanut butter and jelly sandwich for their dinner. Preferences around religion and culture. It's really, one of the things I don't know that we've stressed enough here throughout this summit is the need for sort of a higher level of cultural competency among the profession, among the agencies, and among the nurses, and both ways. But as a nurse and as an agency steps into each individual household, that all of those households come from a different background, and they all deserve to have their personal life play out the way that it would have should their family not need a medical person in their home with them. So there's certainly steps that families have to take to prepare a space to be a safe workspace, but we should all be really conscious of not stepping on that family's ability to practice their own culture and to be the people that they are. So other household members' sleep schedules can be important. There are a lot of times that families work different hours. Oftentimes the nurse is there so the family can work, but there may be naps happening for other kids or things along those lines that it's helpful for the nurses to know so they don't step on feet or upset families. And then peak bathroom times. Nurses need your bathroom is their cleaning station. So being really, these seem like such small things, but when you're a family trying to get everything done and get out the door and your bathroom is taken up for 10 minutes by somebody washing syringes and you're now late to work because you couldn't get a shower, just prepping families. That's the other thing that this document is really good for even prior discharge for patients who are coming home for the first time. This kind of gives them an overview of the mindset that they might want to get into to prepare themselves for the really strange, awkward, but wonderful world of having home care workers in your home helping you. Just talking again about that home as a workspace. Some families prefer that the nurses not wear scrubs because they don't want it to be super obvious that they're that they're receiving nursing care. That's a rare occasion, but those are the little things that can go a long way for a family feeling comfortable, and for that relationship, that triadic relationship, to stay healthy. Or conversely, families may want to make sure that the nurse always has their scrubs on, make sure that they always have their ID, make sure that they always have certain things to identify that they are a healthcare worker, and to help that family navigate the world better, knowing that that's a medical professional that's going to help that child or that individual. Things as simple as, how do you want the nurse to enter the home? Should they come in the side door or the basement door? Is there an alarm system? Are shoes allowed in the house? What should you do if shoes are not allowed in the house and OSHA says you have to wear shoes in a workplace? Laundry preferences, supply locations, trash protocol. There's so many things that when an agency is sending a nurse into a house, they don't recognize how many stumbling blocks they might be putting into that nurse's path because they didn't check in with the family about all this stuff beforehand. Nap and bedtime routines, school routine, if that's applicable, nurses who are taking kids to school or riding along with kids from school need to have the transportation info for pickup, or if the transport doesn't come pick them up, etc. Expectations of the nurse's involvement at school. I know my son goes to a school, my trach vent dependent son, his nurse accompanies him to school or else he wouldn't be able to go. And his pre-K class is full of kids with medical complexities. And the difference in even the way the nurses interact with the child that they're there with, the teachers will tell us, we have a really strong routine with our nurses. Maybe it's my special ed background. I kind of get everybody in on the education front. But my son's nurses are very hands-on with them at school. They're helping them do their OT. They're moving them around. They're helping them clap their hands, making sure that they're engaging. Some of the other kids' nurses are just hanging back and waiting until it's meds time. So having an understanding of what you hope the nurse will engage in while they're at school with your child is really important. Daytime routine, their wake time, their nap times, their scheduled therapies. Nurses often find themselves pulled into OT sessions and PT sessions, and that's not what they're trained for, but they're certainly jumping in and doing it more often than not. Hygiene routines is really important. Everybody bathes someone differently. There's a standard for how you're taught to bathe someone, but as someone mentioned earlier, one family might not want you to use this one kind of underpad. They might want you to use another kind of underpad, or one kid gets bathed in a bathtub and the other one still needs a bed bath. Recommended diaper change frequency, nutrition of how and when the child is fed, what the food options are, allergies, mobility. Does the child sit or stand unsupported? What can you do to encourage sitting if that's something that the family wants or that the PT has worked on? What adaptive seating is there for the child? The thing that's so travel info. Quick side note story about how interesting, and Victoria, I'm sure, can also attest to this. Not every nurse comes into the home with kid experience. So if you are a pediatric patient, your nurse might be wonderful and super skilled and really great with your child. But we've had nurses who didn't know how to use a car seat, and it didn't even occur to me until we were already trying to get into a car to the appointment that nurse didn't know how to safely strap my son into a car seat. Mm-hmm. So I would strongly encourage, agencies that if they're doing pediatric care, they may want to look into having some car seat safety training information available for their nurses. Communication and social engagement supports, I think, is one of the biggest needs of a patient, pediatric or adult, that isn't necessarily lined out for nurses, but is so important in being able to deliver effective care. If you don't know what if a nonverbal person has certain habits they engage in when they're uncomfortable or when they want a certain something, and you don't know those cues, you're not going to provide effective care for that patient. You're not going to recognize when they're in discomfort or in pain. You're not going to recognize when they just need a little more attention. And this goes on. Cognitive and academic support, family goals is one that's, super important, that doesn't often get a lot of attention. What personal goals do you have as a family for your loved one? To go more places together as a family, to have more shared meal times that the nurse can help facilitate when they're there, to make sure that they help get the child to the table or the adult to the table. Where do you see your loved one in 1 year, 5 years? Just so everybody is forward-facing, future-facing for that patient. And not every patient has, my son, we're really fortunate. He's cognitively typical. He's developmentally delayed by way of his physical needs. So that means that he has real big goals. He has some real big goals that he's going to achieve. He's starting to finally sit up at 6 years old. He's interested in standing, even though his body won't do it. But it will someday. And the nurses know that these are the things we see for him. They know that he's going to be a kid who goes to school. He's just going to stay really small and he's going to have bad joints. And someday he won't need his trach and vent. So I think the nurses and the agencies really understanding what the families want for their loved one and the way, or if the individual has the capacity to express that themselves, for everybody to be on board with supporting those goals. Clearly, the nurses need to be aware of emergency protocols before they get there, contact information. I can't tell you how many nurses, agencies in general, and for very good reason, don't necessarily encourage families and their nurses to exchange personal phone numbers. But the reality is, if a family is off at work and their nurse is the only one home with their child, to call the agency's office so that they can then call the nurse, so that the nurse can then relay a message back to the agency to then relay. Would you do that with a babysitter for your typical child? Not that nurses are babysitters, but if you had somebody caring for any loved one in your life, would you want to go through 2 or 3 steps, the answering service, then the person, and that, to be able to find out what's going on in your home with your loved one? So I think some barriers and some of the some of the lines have to be blurred in the sense of what's okay in terms of boundaries. But many nurses tell me that they don't have the caregiver's contact info. So if something happens in the home and the mom is at work, they can't just let the mom know or call the mom to ask what to do. They have to call the agency, wait for a call back from the agency. Then the agency calls the mom. And then by that time, the child is in distress or the adult is on the way to the hospital because the nurse didn't have the right information. It's also important for them to have, contact information for the DME companies, for the specialists that the person is being cared for by. And none of this exists in the plans of care that are utilized at the moment. Agencies can, agencies and families can adjust this up and down as they see the need, or as they see as potentially actually actionable. And I don't know, Victoria, if you have this is our example of, a guideline for how you could maybe build your own template. We have Victoria's binder is a pretty great example that is not necessarily something that her agency made, but it's something that she made to prepare the nurses for delivering effective care to her son. So I don't know if you feel comfortable just sort of holding up your binder. I wish we had a fancy document viewer.
I know. It's something I can make sure we get on the website though, for later on the TAFNNN website. I'll make sure we get something up. But yeah, this is, we call it his white book. This is his white book. It goes everywhere with us. It's basically a one-stop shop for everything that anyone could need to care for him. And I don't mind sharing this, Megan. I don't know what you want me to go into, but I can just quickly tell you the things I keep.
Flip through. This is a weird aside. I'm going to have a morbid aside. The other reason that this is incredibly important is that something could happen to me or Victoria at any moment. And if we are the only two people who know the full extent of our child's needs, then there's going to be a real lack of continuity of care and a potentially dangerous situation for a patient. Yeah. So with that in mind, because I know that internally we've also talked about creating resources for families for emergency preparedness themselves. So this is one of this, this is sort of twofold. Go ahead.
Yeah, and that's kind of what this was born out of, like you said, a twofold thing of being able to help the nurses, but also, God forbid, if we were in a car accident or I was incapacitated for some reason, anybody who grabs this book is going to be able to care for him until additional family can be contacted or whatever the case may be. So in here, I keep, the first thing I always have is his med sheet, and this is the way I write them out. I go in chronological order. I think anybody who is a nurse or works for agencies know it's really difficult with all the addendums and meds constantly changing. Nothing is in the right order. So this it's a second way for the nurses to double check what they have in their books and their tablets, however they keep that information. So this is his med, feed, and TPN schedule that I have in here. Then the very next thing, I have his emergency procedures. So anything that they would need to do for seizures. He does have an epilepsy disorder, as well as blood sugar issues, and how to start his D10, when to call 911. All of those things are in here so that the nurses don't have to question, who am I contacting for what? That's all in here. When to go to the hospital. The very next thing that I have is what I like to call his medical resume. That's in here. So I go through his diagnoses list and do a little bit about each diagnosis and what medications are associated with that diagnosis. Because a lot of times, in his case anyway, there are meds that you might think would be used for one thing, but in his case, they're used for something else. So it just kind of is a cross check for the nurses as well. And then I have his allergy list, and I also have his med list broken down this way, which is what the hospitals like to see. So when we walk in, if I hand this to the attending, if we're going into the ER, this is just a quick check for them to run through their list, and they can match it up and make sure it's all there. I have his emergency contact info. This part I can't show you, unfortunately, because I do have some of his providers' personal cell phone numbers, so I don't want to get in trouble for sharing that, but I keep his important contact information. Cole does have 30 specialists that we see and 4 therapists, so everybody's information is listed out, but I also have notes on when to contact each person to make it easier. I keep things like fax numbers if the nurses need orders, what building they're in, things like that. If they have a certain scheduler or person to talk to in the office to facilitate a phone call for the nurses, that's all notated in there as well. I keep his surgical history because that's often a question in there. And then I just have a bunch of information about anesthesia protocols, considerations with someone who has mito. Now this is where we started to get into additional things. I have his day-to-day care. So like Megan mentioned, things like his nap schedule. I have a list of things that he really likes and a list of things that he really dislikes. So again, the nurses know like, oh, this toy is going to work for him, or no, he doesn't like movies, but if we put on Paw Patrol, and then all of his supplies. And then I also keep labs and letters from doctors and things like that as well. But like I said, we'll make sure this stuff is available on the PAFNNN website as well.
So I know it's possible that providers are feeling like, well, we do some of this, and this may be double work. And that's why I think, the reason that it probably feels like double work is because theirs isn't as comprehensive as yours is, and yours doesn't have all the regulatory needs that theirs does. So if we merge these worlds, how great would that be? And wouldn't it attend to some of that need when nurses are encountering a behavior or something along those lines that they're not familiar with? Catherine did put a comment that said, I have a book too, Victoria, for Mariah. So she,
that's great.
Another family chiming in like, yep, I do this too. I'm curious if any of the attendees still in the chat would want to pop some stuff up or raise their hand to recommend or suggest ways that they could see this used or how it could be helpful. Even going back to the family council model, any questions? You know, we have a little more time. We're getting close to 3:30, but is there some information that you could see being also beneficial or helpful to nurses, or some limitations to this, so that we can make sure that we're taking that feedback, and when we're trying to help agencies and families implement this type of thing, what could we do? I think I see a hand raised there, and it's not letting me click on it. Dana in the chat from PHLP says that binder would be extremely useful in the prior auth and MA appeals process. And one of the things that did come up in the OMEP Shift Care initiative, when we shared these resources with that group of folks, someone else had also from an MCO said, wow, this could be really powerful in helping authorize their nursing hours, because it would give us a better understanding of the full picture. So if something like this was systemic, was a systems approach, wouldn't that be great for the insurance company to have that full picture instead of all these appeals
Yes.
to get there? Any other co-hosts that are able to attend to that raised hand? Because for whatever reason,
So when you're ready, I can unmute Catherine to speak. Are you ready?
Yeah, go for it.
Okay, Catherine, you're unmuted.
Hey, okay. With Mariah transition to the adult system, this is a whole nother segment to go to transition into the adult system. I actually created a binder for her new physician. It took me, we had a hard transition because we sought out doctors who said, yes, we could handle her care. It was a disaster. So I spent 7 months with this doctor, got absolutely nothing done. I had to go back to CHOP, and CHOP has a MENT program that you go in and you sit down with this team. They do exactly what we're talking about today. They sat down and they talked to me. What are you looking for in a physician? What do you want? What do you think Mariah needs? And how do you think that would look? And from a 3-hour appointment, it was the best 3-hour appointment. I didn't fuss or anything. When they came back, they recommended this particular doctor, and it was going into a new system, into the Jeff system. But when I tell you, this has been the best relationship ever. She gets it. She understands. They matched our personalities. And when I walked in and I gave her the binder, she said, what's this? I said, everything that you're going to need to know about your new patient. And she opened it up and she just started smiling like, wow. So it made it easier for her staff because we were new. I had to get to know them. They had to get to know me. And like you said, you guys don't even know this, so I'm getting ready to tell you this for the first time. In November of 2019, I had a stroke. Yes. And it was out of the blue, happened at night, and I ended up, I told the nurse, I said, I have to go to the hospital, and I left. However, had anything else happened to me, that book, which I call the Bible, Mariah's Bible, they can continue to take care of her. The guardianship paperwork is in there. I have an additional addendum to that. If I become incapacitated, her sister, who is now an adult, steps in and can make all of the decisions for her. The guardianship piece is something that is not being readily talked about. I've done probably 3 workshops on this because it is extremely crucial.
Yeah.
The insurance company don't have to talk to you. The schools don't have to talk to you. The pharmacies, no one. And you don't understand how one day somebody's going to stop you. Somewhere, somehow, if it's not done when they become of that age. Yeah. So, and I was incapacitated for 24 hours, and You know, my daughter, you know, she was like, I have it, Mom. And she said, I got the book. That's all she said. Yeah, I got the book. And I was almost at peace with that point because I knew that Mariah would be okay. And then her nurses, they know exactly what to do, you know, if anything happens with her. But we have to just continue to educate our families in regards to precautions, being proactive versus reactive.
Being
I can't
prepared.
think in an emergency. You know, you're being a mom. You're not being an advocate. You're not doing that. And you know, and when you get to that point, it's like, what do I do? But if you have that go-to, I call it my go-to book. Everything is in there. Everything is in there. But I definitely agree with that. And the piece that you guys spoke about regarding the agencies and the relationship with the caregivers. I actually had to have a meeting with the agency in regards to that particular, and the analogy that I gave them, I said, oh, Victoria, what time do you go to bed at night? And young lady was like, okay, I go to bed at like 10 o'clock. I said, I'm gonna get to your house about 9:30. I'm gonna sit in your living room and you can go up and go to bed. That's how crazy it sounds when you want nurses to come into your home and you don't want us to have a conversation with them. You don't want us to talk to them.
Yeah.
That's nuts. And I said, we can't do that. And that's where the relationship, and do I have to tell some of my parents? You can't go and be so personal with it. You still have to keep a line of professionalism, because when you don't, the waters get murky and then somebody gets upset somewhere and now you have a whole problem. So.
Yes. I think that really brings us back to that, you know, really the ultimate goal here. And listen, it's not to say that, you know, we really strive to make people change their view around what they consider a problem case or a problem family, and reconsider if that's a family with more problems. And the same, but you know, there are harder to handle families. There are harder to handle agencies. There are harder to handle nurses. So there is absolutely, you know, we're not going to pretend that there aren't entities or people involved that aren't problematic, just by way of problems, but not because of their problems, because they are just a problematic person for the situation that they're being put in. But largely, I think where the problems come in is the misunderstanding of each entity in that triad, and mostly around the family and that experience of having home care in your home. So the more we can encourage and support all the players in this wacky game that we all live, to be proactively prepared on multiple levels, and to really be working endlessly to foster those relationships and partnerships, I think is going to be what takes us to the start of a transformation in healthcare and home care, even though we know the big wheels turn slowly. So we're the little wheels moving everything along every day, and us little wheels can start changing. And when we start changing the culture on the ground level, and we start being more proactive about helping families be prepared, when we start being more proactive about matching families, nurses, and agencies in a better way, and not being so proprietary about holding on to things that don't fit, and when we start making sure that there is actual representation of the families that are being served in the agency, and that the agencies and the nurses have some level of cultural competency for the homes that they're going into, I think we're going to, the changes we make in the implementation, they're gonna drive it up. We're gonna drive it up to those systems, and the systems want to change. It's going to take some time, and we're going to keep it all trucking until we all get there. So that's our time. That was the 2020 Nursing Summit virtual format. I hope everybody who attended walks away with something helpful and some piece of information that you carry with you. I really appreciate everybody who took the time to be here. I can't thank Victoria, Gloria, Dana, and Amy, who have been in the background making everything flow this whole time. Can't thank you all enough for planning this with us and just being so instrumental in bringing this information to all these folks. Once again, Vision for Equality supports PA Families Need Nurses Now. Of course, like all small organizations, we need ongoing support. So please do contact us if you want to become more involved, if you want to help us. We are pafamiliesneednursesnow.org, or you can find a link to us on Vision for Equality's website. So with that, I will say thank you, and everybody enjoy your day and stay safe and healthy, and don't forget to vote.
Thank you.
Bye, everyone.